How are you?
Dr. Alboran joined. Dr. Mitra ma'am, please start. Dr. Mitra ma'am.
Satyavan.
Hello, Dr. Albaro. Welcome.
Has he joined?
Yeah.
Yeah, yes. Wow.
Dr. Mitra ma'am, please start. Answer madam कुछ वो कर रही है. Hello, Dr. Mitra ma'am.
Yes.
Please start ma'am.
जाने वाला पढ़ से गया.
Dr.
Mitra, please start.
Should we start?
Please. Yeah, go ahead.
Okay. Can you make it full screen, Nilima? Nilima, can you make? Okay. So, Dr. Sheila, shall I start?
Mitra, start. You've
Okay,
already
please.
said.
Okay. So a very warm, loving good evening to every single person who has spared their precious time to join us for this wonderful FOGSI ICOG Masterclass on understanding and managing placenta accreta spectrum. Dear friends, we all know that our ICOG, the academic wing of FOGSI, has left no stone unturned to continue fantastic academic proceedings day in and day out for all of us to increase our surgical academic knowledge. So it's a very, very proud moment for me and Dr. Manju Puri to convene this special masterclass on understanding and managing placenta accreta spectrum. And on behalf of Dr. Manju and me, I would like to welcome the ICOG team, our chairperson, Dr. Sheila Mane, Dr. Ashok Kumar, the chairperson-elect, Dr. Sadhna Gupta, the vice chairperson, Dr. Pratik Tambe, secretary ICOG, and our FOGSI team, President Bhaskar, and Secretary General Dr. Suvarna, who are backing every program of ICOG. I would not, like to spare any extra moment because we are very hard pressed for time today. And that is the most important commodity when we are even dealing with something as emergent as managing hemorrhage in a PAS case. Also, I would like to welcome the seniors of our federation who have joined and our wonderful faculty, Dr. Albaro from Colombia. It is extremely early morning in Colombia, and thank you, Dr. Albaro, for joining in. I will not be able to mention everybody by name, but it is really a happy moment to see that so many of busy practitioners, obstetricians from all walks of life in India are here with us today. So without much ado, I will welcome Dr. Sheila Mane to give her address as the chairperson of this federation, ICOG. Dr. Sheila.
Thank you. Yeah. Thank you, Dr. Mitra. I would like to thank Dr. Manju Puri and Dr. Mitra Saxena for conceptualizing this masterclass. All of us, we know that both of them, they did a tremendous work by arranging 4 workshop where there was a hands-on training by Dr. Albaro, and many people could attend that as it was hands-on. I think the registrations were not so many, but we thought ICOG gives us a platform where by the way of webinar, we can spread this knowledge to all our FOGSians and all our colleagues. All of us, we know that placenta accreta is becoming a very common entity due to rise in the incidence of cesarean section, and we would like to see to it that our knowledge is better day by day. And I'm sure that today's masterclass will definitely give us so much of enrichment in our knowledge that we will be able to manage it in a proper way. I think I would like to talk more at the end of it because we are waiting for everybody to give their address. But I'm really happy, and I think we will be also coming up with a conference where we have this workshop, as well as we will have one more certificate course also. And those who have joined, I am really thankful to them, and I know many more will join, as well as the faculty like Dr. Saha and Dr. Sudarshan, everybody, those who have joined. I know the major role will be played by Dr. Albaro. And Dr. Albaro, thank you very much. I know it is a very early morning for you, and you have obliged to be there in our webinar of ICOG. And I think we are really privileged. And like an Indian, I would like to say that I would like to thank you. Thank you very much. Okay, over to you, Mitra.
I will invite Dr. Pratik, our secretary of ICOG, to share his thoughts on this wonderful masterclass. We all know Dr. Pratik Tambe is the most consistent, a very sensitive, and a very sincere, silent worker. So 3S for you, Dr. Pratik. Over to you.
Thank you very much, Dr. Mitra Saxena, and the organizing team led by the conveners, Dr. Manju Puri and Dr. Mitra Saxena, the coordinators, Dr. Renu Yadav, Dr. Nivedita Jha, and Dr. Indira Prasad. Thank you very much for curating together a beautiful program, which is very much the need of the hour. We often find that many of our younger generation are not very much interested in taking up high-risk pregnancy and high-risk obstetrics, primarily because of the increasing incidence of complications, especially those complications which are not diagnosed before the patient is on table. Placenta accreta spectrum is one such set of conditions. We are seeing these patients with more and more frequency in today's world. And as I'm so fond of saying, India is a land of great diversity. Unfortunately, not everybody practices in a setup where blood bank, a big team of residents, multidisciplinary care, good anesthesia, internal medicine facilities, and ICU setup, or even an HDU is available to all of us. Therefore, it is necessary for us to be able to diagnose this condition antenatally, make sure that the patient is operated in a good tertiary care where all facilities are there. Forewarned is truly forearmed in this particular set of conditions. And I think today's masterclass will go a long way towards educating common OBGYNs throughout the country. Thank you very much for taking up this subject. And I also would like to place on record my gratitude to Dr. Sheila Mane, our chairperson, for initiating for the first time the PAS registry for India. I think this will go a long way towards educating and teaching all of us regarding this condition. So thank you again. Let's proceed with the academics.
Thank you, Dr. Pratik. As always, you are very much, on board, and you are absolutely bang on bullseye. These are the most important messages. If Dr. Parul has joined, I would like to invite him. And if Dr. Parag, can somebody please? So I will request Dr. Parag Binewale to share his thoughts. And friends, I actually requested that we will not flash CVs because every obstetrician knows all of these luminaries. We know that Dr. Parag has been the immediate past chairperson and one of very, very important facilitator for Dr. Manju and myself when we organize these workshops. So over to you, Dr. Parag. Please share your thoughts.
Thank you, Mitra. Good evening. It's indeed a pleasure to be in the ICOG program, and I must appreciate the work done by the chairperson, Dr. Sheila Mane, ably supported by the secretary, Pratik. Mitra and Manju, what can I say about this program? Because you've already done it. You've already proved its worth and how important this topic is and how well it can be executed. Hats off to you, and I'm sure today's program also is going to be a great learning experience for all of us who've missed out on those 4 programs which you've done earlier this year. And even in those programs, ICOG was happy to be your academic partner, and I'm sure under the able leadership of Dr. Sheila Mane, we will continue to do such activities because for Sheila, PPH is her forte, and whatever it takes, she will, take this to all corners of the country so that each and every obstetrician learns the nitty-gritties of this problem, which is on the rise. So thank you for having me here, and I'm looking forward to a great learning session.
Yeah. Thank you very much, Dr. Parag. Has Dr. Parul joined or any senior is there? Dr. Sheila, would you like to invite somebody?
Parul ma'am not joined yet, ma'am.
Dr. Parul is here?
No, ma'am.
Okay.
We have, I think Dr. Arup Maji is here, our senior. Dr. Jyoti Bindal is here. I think.
Yeah, they are chairpersons. Yes, they are there.
Okay.
So I thank all the seniors who are joined today. And friends, I just want to say one thing for Dr. Sheila Mane. Because you know what? I have found that this person is the most dedicated obstetrician, somebody we all actually look up to, because from the time she has been in FOGSI, I think she has dedicated herself to big missions. I went through her CV, but then I thought I cannot share it. But the few things I just want to say is that in her role as FOGSian, when she took up the chairpersonship, the vice presidentship, and now the ICOG chairman, I think the most important lesson to learn from Dr. Sheila is to be very focused and to be very inclusive. Thank you, Dr. Sheila, for giving us this, responsibility to carry it out. Friends, there is a disclaimer because Dr. Alvaro has joined us from Colombia, and we have tried to make sure that all the presentations reach you in good transmission and all that. But in case there is any hitch of net connectivity at your end, just bear with us. Now I will welcome our coordinators, Dr. Renu Yadav, Dr. Nivedita Jha, and Dr. Indira Prasad, 3 dynamic, very busy obstetricians who have agreed to coordinate this program. Nilima, can you please show the slides? So Dr. Renu is a very sincere, good, dynamic vaginal surgeon, deals with high-risk pregnancy, and she practices in Mahendragarh in her hospital, Shrabati Surgical and Maternity Home. And of course, I am very privileged to be her best friend. Welcome, Dr. Renu. I would like to invite Dr. Nivedita Jha, who is an additional professor in Department of Obstetrics and Gynecology, JIPMER. A line about Dr. Nivedita. She's one of the very, very enthusiastic delegates of our workshops. And I think, Nivedita, the interesting thing was that you gave the name PAS another connotation of Palacio-Alvaro spectrum, because Dr. Jose and Dr. Alvaro both named, she clubbed it together. So welcome, Dr. Nivedita. And I have Dr. Indira Prasad, additional professor from AIMS Patna. I'm not going to read all her CV because it is so impressive, but thank you, Indira, for being one of those younger leaders to lead the juniors and to, emulate your seniors, your teacher, Dr. Manjupuri. Welcome to all my 3 coordinators. And now I hand over the mic to you, and let's begin with the scientific session. Yes.
Thank you, Dr. Mitra. Now we can start the first scientific session. Nivedita, please share the CVs. Yes. Now we'll be starting the first scientific session, which has got 3 talks regarding the guidelines, the imaging, and the burden of PAS, for which I would like to invite Chairperson Dr. Jogita Uni, who is a senior consultant at Fernandez Hospital, Hyderabad. She's also a member of the PAS team at Fernandez and has a huge experience in managing high-risk OBGYN cases. She's also running various training programs And I'm also happy to share that after attending our PAS workshop at Kolkata, she got the opportunity to apply the principles and do a one-step conservative surgery in PAS. Welcome, Dr. Jogita.
Thank you so much.
Thank you. Welcome. Now I'd like to invite Dr. Arup Kumar Maji, who is a very senior professor at Shanti Niketan Medical College, Bholpur, West Bengal. He has delivered various orations and has various publications in national and international journals, and is also a governing council member. Welcome, sir. Sir is there. And lastly, I would like to invite Dr. Achla Batra, who has been working at VMMC and Safdarjung hospitals, and she's a governing council member, ICOG, and running various FOGSI projects. And she's also a master trainer for WHO. Welcome, ma'am. I would like to, Dr. Jogita, could you invite the speaker, Dr. Mitra Saxena?
Yeah, thank you so much. It's my great privilege to welcome Dr. Mitra. She's our opening batsman today, and she's going to introduce us to the spectrum of placenta accreta. And Madam does not require any informal introduction. Amongst her many accolades, she and Dr. Manju, they have been the driving force behind unique educational sessions. These sessions are aiming at imparting knowledge for clinical application, not just for sharing information. So, Madam, I will not waste any more time.
Thank you. I do respect that. We have to respect time. Thank you so much, Dr. Jogita. Nilima, please allow me to share my presentation. Are you able to see my slide? Is it visible?
Yes,
Yeah,
ma'am.
please go ahead.
Yes.
Okay.
Yes, it is highly
Okay.
visible.
So dear friends, we are going to begin our journey with PAS from fear to balance. We began in ignorance around the 70s. We met placenta accreta unprepared and lost mothers to uncontrolled bleeding. Then came fear. Remove all you try to save the mother became our reflex. We swung from underprepared to over radical. Hot heads, morbid surgeries, and remember, young lives altered forever. The one thing peculiar about this life-threatening trouble is, and shall be, it's a bomb. The threatening bomb of PAS has exploded globally because the main culprit, the rising cesarean section rate, overtook the human birthing. This is not my opinion. This is an epidemiological fact. We as obstetricians lit the fuse with every primary cesarean section for precious pregnancy, for patient request, for
Yes.
CPD, for
Yes.
convenience. We planted a placenta previa on a scar. This no longer is a high-income country problem or a low middle-income country problem. This is a human problem. Now, we are all familiar with multiple graphs of the world, of our country, of different areas where we have different rates of cesarean section. But the final answer is that we have induced an iatrogenic epidemic, which is the PAS. And I have called it the PAS paradox. Bear with me why it is a paradox. It came into existence because of the exponential rise in cesarean sections. And of course, when it took the obstetric world by surprise, every country's associations, whether it was RCOG, American College, or the FIGO, or the Society for Fetal Medicine, there were exhaustive studies, analysis, searches to arrest on-table hemorrhage and formulate guidelines to find safer solutions. Not until the last decade, it became evident that many of the uteri that were removed didn't actually have the pathological adherence. So what was it? Between the options laid out for high-income countries and low and middle-income countries, the disease is the same, the resources are not. So it's two worlds, but one disease. Now, lots of classifications are there. The details of this, whatever is relevant, will be covered by Dr. Manju Puri. But suffices to say that what we already know are the three grades of placenta: invasion, the accreta, adherent, the invasion, the increta, and beyond the serosa, the percreta. We have to appreciate that something which was 1 in 4 digits, 1 in 3,000, has actually over the period of 3-4 decades, the incidence has increased almost by hundreds, 300%. But the good news is that the commonest amongst them is just adherence, placenta accreta, and the increta and percreta are much lesser. So if we are doing too much aggressive management, that is the paradox. So today we all know that the pathogenesis is there for all of us, and we know that it is defective deciduralization where there is damage to the endometrial myometrial interface. And as already known to all of us, cesarean section with the placenta implanted in the lower segment is the most important risk factor. Let us remember this very important line that the seed is normal, the soil is not. And the soil which has bad healing because of a previous scar, that is the most important reason why that seed would adhere to this site, and it is going to cause havoc. So even if there is no invasion, just by being there in a niche is going to cause trouble. So that is the confusion, whether what are we dealing with, whether it is actually a PAS or it is just adherent. So let's also not forget that there is a very big debate about the existence of percreta. Is it true invasion or just a scar dehiscence? But suffice it to say that it's by 16 weeks the die is cast, because whether it's going to be accreta, increta, or percreta, that will be confirmed by a very good ultrasound. And increasing depth of invasion is not related to increasing duration of gestation. We have to remember that 80% of patients with PAS have a history of previous cesarean section, curettage, and or myomectomy. Now, we are all very familiar with these risk factors. All we have to say is that when there is increasing in the number of cesarean sections with low-lying placenta or placenta previa, the incidence of PAS is many fold. So the adage is that if there is a previous cesarean with a placenta, it is, unless proved otherwise, considered as PAS. On the right side, we see if there is no placenta in that area, we're actually not afraid of any number of cesareans that have been done. This is another collection, a more recent compilation of 44,000. Again, we see the same spread. Now, we all know the other risk factors. I'm not going to enumerate here for all of you, but just remember, if we have not been gentle to the uterus, it's not just in the lower segment, it is also in the upper segment that the placenta could be adherent. So how does it present clinically and what are the consequences? It could be an asymptomatic presentation when the sonologist reports that the placenta is low-lying. And if we know that this is a previous cesarean section case, the bell or the red flag should be there. And sometimes when the placenta is in the upper segment or there is a previous myomectomy or any curettage, it could be just that when you're doing an MRP, you find there is no line of cleavage and there is torrential hemorrhage. Another thing is during cesarean, when you're doing all the dissections, of course, you're facing PAS, and with all the complications, it can be landing with hysterectomy, transfusions, bladder injury, so on and so forth. So a word about cesarean section scar pregnancy. The details are going to be taken by our coming speaker, but let us just remember it, that if the niche is not good and if it serves as a nidus for the gestational sac, it's a baby PAS, better to get it out. Now, coming to the fact that what is it that we are afraid of when we are dealing with PAS? It is the most dreaded complication, uncontrolled hemorrhage. So we all know that ultrasound screening is our first tool, which will put us on a good, alarm, and we will take all the precautions to see where we stand. Can we deal it at our center? Do we need help? How to do? Now, I'm not going to go in the details because we have an excellent speaker after me who's going to take us through all this and simplify the understanding. My only message to all the obstetricians is that please listen to it carefully. And when you are dealing with ultrasound reports, please do not read the typed reports. Just look at the images, and Dr. Sudarshan is going to describe it beautifully, how we can recognize even at 2D how a placenta accreta spectrum looks like. Now, coming to the fact that then Dr. Bose and Dr. Albaro have done phenomenal work in finding out the culprit vessels in the lower segment. And I will leave it to Dr. Albaro to discuss the anatomy, because what I feel is that surgery matures with anatomy. It's a time for us to go back and revise our anatomy. Also, let me conclude my talk with this PAS management pyramid, where we have to make sure that we can prevent it, we prepare ourselves, and we respect and perform, do a good planning. So the tier 1 is antenatal preparation, which is the war room. Remember, 80% of PAS mortality is decided before the first incision. The pillars are accurate diagnosis, preoperative planning, and patient counseling. In high income groups, of course, they have better techniques. So they are including MRI. There are specialized placental clinics to do the ultrasound. Here we have to just make sure that our sonologists understand this 3D conceptual ultrasound. We don't need MRI. We only need to see the placenta in 3D during every scan. About preoperative planning, if you have the facility, of course, it is better to have interventional radiology, multidisciplinary team, blood bank, and everything. But for us, where we are, we can upscale our skills and do a surgical rehearsal, walk through the surgery in our head with the time night before. Patient counseling, of course, we know that consent is not a form, it's a conversation. So when we are dealing with such a patient in the whole antenatal period, we have to make sure that the patient and the teams all are prepared for the last act. Coming to the tier 2 intra-op skills, which is the battlefield, where you have to make sure that if you have good technology, you are fortunate. But if you're not, then your techniques, your understanding of the surgical skills has to be perfect. And I can assure you that in the last part of our sessions, you're going to witness everything through videos and teaching. There can be no, dogma about this is the best. The decision tree, you have to understand the importance of all these single steps, the bladder dissection, how to deliver, when to consider each option, and the concept of devascularizing which vessels when. This is non-negotiable, and choosing the best option. Confirm that we do not cause more damage than, the best line that I liked was, leave no questions for the night team. That is what we should, follow when we try to undertake this management. And the last tier 3 is the prevention, the only true cure. Decrease the primary cesarean section. I know it's a tall order, but every time that we do cesarean sections, we know the patient may come back to us. And if there is something wrong in our technique, we may land up with PAS in our own series. So encourage feedback where you can. There is a very good study which Alvaro and Dr. Jose are doing. What should be the site of hysterectomy? And meticulous closure, this goes without saying, and I'm sure Dr. Manju is going to elaborate on all these things which are very important, which are coming back in circles, how to close the uterus to make sure that the healing is good. Screen for niche anastomosis. We can incorporate this in our, the way we manage our patients, that 6 weeks later when we call them for a postnatal checkup, we can even do a follow-up ultrasound to see how our cesarean section has healed. So I would say there is self-learning in all of this. And of course, if we diagnose the gestational sac in the niche, let's evacuate it, because that's the way to get rid of PAS at a later date. And now I conclude my talk with the 3 aims of this masterclass. Let us create PAS champions. So those who are PAS conscious, those who are PAS competent, and PAS documented. So I'm happy to inform you that Dr. Sheila Mane, tirelessly has worked towards developing this registry, ably conducted by Dr. Aruna and Dr. Manjupuri, which is going to be shared at the end of this session. Thank you, friends, for your patient hearing. Over to the coordinator.
Thank you, Dr. Mitra. I would now request Dr. Maji to invite our next speaker, Dr. Sudarshan.
Thank you, Dr. Mitra, for your excellent talk. What's a view about the? So you always, the first 2 things you do, I do not do. That is the document and auditing, and for the future. Our next speaker is Dr. Sudarshan. Will you please project the slide, please?
Nilima, please share Dr. Sudarshan's.
Yeah, share the slide. Share the slide. Yeah. And in fact, ultimately we'll have to depend mainly on the imaging technique. After 2018, there is a dramatical change of the management of the sac. Initially at the removal of the uterus, now more conservative surgery, but everything depends on the ultrasound findings, not only antenatal, and also the internal ultrasound is also done. So we have a very stalwart speaker, Dr. Sudarshan, who is the consultant fetal medicine and therapy medicine system, and she is the clinical lead fetal medicine fellowship program medicine adjunct faculty, conducted multiple workshops on fetal echo, Doppler, fetal intervention, organizing secretary CASP, the national conference in the fetal care, invited speaker at the national conferences, awarded Jubo FOGSI Oration 2021. So now, Dr. Sudarshan, it is your time to present and to give us the delivery of the important part, the imaging in placenta accreta spectrum. That is also guide the obstetrician. Dr. Sudarshan, please. And my also thank to the twin, that is the Dr. Mitra and Dr. Manjupuri for organizing such a beautiful webinar today under the guidance of the FOGSI ICOG leader and the FOGSI leader. And they have assembled so many beautiful speakers today. The imaging in PAS, Dr. Sudarshan. Will you share the slide? The coordinator, please.
Dr. Sudarshan, please join.
Renu, just see he's not muted or something. Renu?
Can you see me?
No, he is not muted.
Yeah, we can see you and we can hear you, sir. Please go ahead and share.
Thank you.
Yeah. Yes, we can see you, Dr. Sudarshan. Yeah, please share your slides. Welcome, Dr. Sudarshan.
I'm just
Welcome, Dr. Sudarshan.
Thank you, sir. I'm just checking if share. I think you should be able to see my slides now.
Yes.
Yes.
Okay. You can see them?
Perfect. Go ahead.
Okay. Thank you so much. A very good evening, and thanks to the ICOG team and Dr. Mitra for having me on this meeting. And probably over the next 15 to 17 minutes, I'll discuss about the ultrasound signs of placenta accreta spectrum disorder from the early pregnancy to the third trimester. A lot of this has been discussed in quite a number of meetings before. I'll try to summarize them into some newer signs which are there reported in addition to the traditional signs of placenta accreta. So when we look at the concept of placenta accreta spectrum as a obstetric and a maternal concern, the primary issue comes in diagnosing the problem prenatally, because only when you diagnose the problem prenatally are you able to make sure that you take appropriate measures to be prepared for handling the crisis at birth, or else we end up with an emergency which happens at birth. Right. So when you look at the concept of an adherent placenta, it happens because of quite a number of reasons which we are familiar, most of which are going to involve having some sort of a surgical management of the uterus at some point of time in prior to the current pregnancy, all of which causes some breakage of the decidua, and it causes the invasion of the placenta to the abnormal site in the placenta, in the uterine wall, where the scar has not healed well. And the types of the placental adherence vary in their severity from being mildly attached to the myometrium to the severe versions where the placenta tends to perforate into the bladder wall. irrespective of the severity, it is essential to identify all three groups because all three groups can have management problems at the time of the delivery. So we start assessment or imaging the placenta from the first trimester onwards. Any placenta that we want to start imaging by from the first trimester, we try to do it in a combined method by a transabdominal and a transvaginal. For the first trimester assessment of the placenta, a transabdominal assessment is more than sufficient if you see an imaging of the placenta this way. And how am I imaging this? When I try to image the placenta, be it across any trimester, I do it in two planes. I usually keep the probe in the longitudinal plane in the abdomen and try to sweep from the fundus to the cervix. And I rotate the probe transverse where I'm getting a transverse section where I'm going from the bladder end up to the fundus again. So by means of doing a transverse and the longitudinal scan, I'm able to see the chorionic plate, the entire placental substance. And if you're able to note, I'm also taking the retroplacental zone, which is also very clearly seen. In this video, I have not even run this video. In the still image, you can see the retroplacental clear zone very, very well. And that means that the placenta is attached to the uterine wall, but it is not deeply adherent to the myometrium or perforating inside. A transvaginal assessment is also done if we see some significant signs on the abdominal scan, or else a good transabdominal scan would be sufficient in a patient where the visibility is good. Right. So we move on to look at the same in the transvaginal scan. In transvaginal scan, essential is to make sure the probe marker is kept on the right side so that you're able to rotate it. And in the transvaginal scan, we usually doing a long scan. If you can see, the whole placenta is in the longitudinal method that is there. And I'm at one glance, because the uterus is small, you'll be able to see the entire placenta from the cervical end to the fundal end fully. And herein I have rotated the probe transverse to do a cross section. So by means of doing a long and a cross section, what we are doing is we are doing slices at different thickness across the placenta to see if there are any areas of abnormality seen within the substance of the placenta. Okay. So we also do the same methodology in the abdominal scan and the vaginal scan in the second trimester. So this is the second trimester video which is showing the entire length of the placenta from the fundus down. What can you appreciate here? The moment we start seeing it, we first see the upper extent and we move across and try to end the lower extent. Any placenta that starts at the fundus, I keep repeating this in all my meetings, will never be a complete placenta previa, because it's not feasible for a placenta to start from the fundus and go all the way and cover the os completely. It's very, very unlikely. And second, as you are just moving across the probe, you can see that there is a very nice sliding movement between the uterus and the placenta. We talk about the sliding sign when we do the adnexal assessment. Even in a non-adherent placenta like this, you can see that the placenta and the uterus are freely moving independent of each other as you slide the probe across. I shall run through that at the subsequent slides. A lot of concepts of simplified assessment of the placenta in practice can be obtained from this good paper which was published recently on a simple guide to the ultrasound screening of PAS disorder, where they break down the assessment of the placenta by three-step process. One, you need to have awareness of the fact that you're going to look at a abnormal placenta, which means we do a proper history to look if there are risk factors for PAS present. And this risk factors, if there are there, the A prior risk becomes more. And like for any screening test, ultrasound is basically a screening tool. You have the fact that the probability of obtaining an abnormal report is higher. So in a primi gravida with no prior uterine manipulation, you're not going and thinking or looking for a adherent spectrum placenta. But in someone with, say, previous 2 cesarean sections, or who have had multiple evacuations of the uterus, then yes, the risk factor is there. The second risk factor you look at is in someone who has got an anterior and low lying or anterior placenta, which is placenta previa. The probability of an adherent placenta is much lower in a posterior placenta. It's rare. An anterior low-lying placenta or an anterior placenta previa are the ones we need to think of in the background history of prior C-sections or deliveries or DNCs, as I have said. Second is we need to understand in step 2 that placenta accreta is a spectrum. That's why it's called PAS, placenta accreta spectrum disorder, because each of the ultrasound signs represent different features in the anatomy on the uterus. We look for neovascularity, we look for severity, and the severity what you see and the ultrasound and the operative findings sometimes can vary. Each findings of PAS will have a different connotation that is unique to that particular case. So we look at three aspects again. One, you are trying to look at the uteroplacental bed. In the uteroplacental bed, what are you trying to look at? You are trying to look at any placental bulge that is there, which happens because of insufficient muscle there to contract, and this bulge can be seen inside the nearby organ, which is the bladder. You look for myometrial thinning, which is very thin myometrium that happens because the muscle is again very thin to contract. And we look for the loss of a clear zone. We saw the clear zone on the videos. When that clear zone is there, so the placenta is fused to the uterus. So in the uteroplacental bed, you are trying to look at these three aspects. Then you go inside the placenta. Here you are trying to look at the substance of the placenta, which looked very uniform in the prior pictures. Herein, if you see large irregular anechoic spaces, specifically if these spaces are connecting with the myometrium behind, then it means there is a destruction of the placental tissue by the high pressure feeder blood vessels from within the uterus. That's why you see all those anechoic areas, and which is why when you switch on the color Doppler and reduce the PRF appropriately, then you will be able to see the vessels showing the flow from the myometrium inside these lacunar spaces. Third, you look for signs of neovascularization, which you actually seen on the operative sign, where on the surface of the uterus you can see all these bulging blood vessels there. These neovascularization signs are seen as bladder wall interruption, which is basically a tangled mat of blood vessels between the uterine wall and the posterior bladder wall. This has been described as varying signs as hypervascularity, bridging vessels, and there is a new sign reported as a railroad sign. But essentially all of them, concept of that is there is a tangled mass of neovascularization which happens, and you're trying to just give it different names on the ultrasound. And with this signs of the uteroplacental bed and the lacunae and the vascularity, you try to punch them into different standard scoring system. The standard scoring system is the PAS scoring system, which is 0, 1, and 2. 3 rare to identify prenatally during the pregnancy scan by ultrasound. But 1 and 2 is what we are trying to see if it is there. And if there are two signs, then it is PAS1 of these three. If there is PAS1 along with the hypervascularity, that is when neovascularization happens, then you call it as PA stage 2. When it extends to the parametrium, it becomes type 3. So you started from 1, 2, and 3 based on the presence of the number of signs. And anytime there is a hypervascularity comes, it is 2. What is important to know is that in all this, appropriate color Doppler application is important, because randomly if you apply color Doppler, it might mimic the presence of a hypervascularity. So you can't have a placenta that is adherent and having a normal retroplacental space, no lacunae, and you only report a hypervascularity. Because I do see these kinds of reports which raise unnecessary queries. So you cannot have a stage 2 without a stage 1, which is why the staging very clearly says it must be PAS 1 plus hypervascularity. So in the absence of these signs, don't go and try to interrogate with color Doppler thinking you may get additional value. You will only create confusion. So let's look at these signs as ultrasound images. We have already reiterated that lacunae are large, irregular, sonolucent intraplacental spaces having a moth-eaten appearance. And there are many placental sonolucencies which can mimic all this, which can range from a placental lake to a hematoma or a thrombus or an infarct. So how do we differentiate this? First and foremost, you need your history in mind. In the absence of any history of placenta accreta spectrum, when you see all these big spaces, then don't think they are lacunae of placental adherence. It is not feasible. Automatically, you have to go for the other differentials that are there. Placental lakes are usually commonly seen during the pregnancy times. These are small irregular spaces. They will have maternal blood in it. And when you look at the ultrasound, you may see these moving internal echoes that are there, swirling internal echoes, very well seen. And when you see swirling internal echoes inside that space, then it is not a lacunae. It is definitely present a lake which has happened because of some thrombus in that area. So when you look at subchorionic fibrin, which is the other differential, so that is seen as a hypoechoic area that is irregular, seen more near the chorionic plate rather than near the basal plate. That's where the lacunar spaces are seen. And again, this will be in a broad area and not those irregular moth-eaten appearance, which is the terminology that we use. So in a placenta like this, you can see these small spaces that are there. These are very tiny lacunae. These are not large, more than 2 centimeters, and these are very tiny, and majority of the placental substance is normal. You can see a beautiful retroplacental space there. So this is a PAS 0. This is a placenta previa because you can see that the placenta is completely covering the os, but none of the signs of adherence are there. So it is PAS 0. I have documented the retroplacental space by means of these arrowhead points that is noted here. Right. So when you look at the second sign, that is the absence of the retroplacental space or the retroplacental clear zone, this is seen in a vast majority of adherent placentas. You can note here that this black space is no longer there. I shall demonstrate by a few videos as we go across to understand the pitfalls here. So in this placenta previa, this is a placenta that is completely covering the internal os. That's the cervix internal os placenta. You can see that all along the lower segment, you don't see a very clear retroplacental space, and you do tend to see. Okay, and then you do tend to see multiple of these spaces inside the placenta. So this is an example of a pregnancy having a placenta previa, but a vast majority of the placenta is showing a normal retroplacental space, except this anterior end, which is showing absence of the space. And the third sign is the thinning of the bladder line. This thinning of the bladder line that you note here happens because of the bulging of this placenta inside this myometrium at the level of the bladder interface. For seeing this, you need to fill up some amount of the bladder. And the last thing is what you look at is the vascularity there. This vascularity, you start switching the color Doppler and looking at it only when you see these multiple lacunae. Without that, you don't tend to see them. And when you see these kind of irregular geographic lacunae all through the placenta and you switch on the color, it fills up that, then you think it is a PAS 2. This is an example of the color flow showing the engorged vessels all through the lacunar spaces going up to the myometrium. This is by a method called B flow, which is there in some machines, where it will pull out the blood vessels alone by means of by white color here. So all the other non-vascular things will be appearing hypoechoic. Only the vascularity will be pulled up. So this is a useful technique to show if there is a true hypervascularity that is noted. So in this particular placenta, you can see that it is just lighting up with color and fiery color that is there all along, and you are able to score it and also show that it is having a significant concern. And the same thing when I'm doing the vaginal scan, you can note the irregularity of the bladder line, and you will never be able to see this if this fluid in the bladder is not there. And you can also see the sign which I told right at the beginning. These lacunae are connecting with the myometrium because these are the large vessels which are invading this and causing these spaces. You can see that the connection of these lacunar spaces is seen with the retroplacental zone, and the myometrium is thinned at the bladder wall interface with irregularity there. And this irregularity, when you switch on the color Doppler, is what is seen as the various color Doppler signs. What I'm going to quickly run through this case is there are some other new signs of PAS which are also being reported. These are the rail sign, the pulsatile sign, and the separation sign. What is the implication of that? This systematic review published last year gave an accuracy of that of all these signs. What have they told? Across first and second trimester, they have seen that the standard signs which I described to you at the beginning have almost an equal sensitivity and specificity in first and second, third trimester, which means that a first trimester screening for high risk PAS can enhance early detection. That is one thing. I'll also show you the newer signs which are reported. One is a rail sign. This rail sign basically is seen as these two parallel rail track on ultrasound. The sensitivity is high, the specificity is low, which means when the sign is not there, then you cannot rule out the problem. But when the sign is there, then the possibility of the problem is higher. And these are the labeling which I have done. So this is your subplacental hypervascularity. This is a vesical hypervascularity, and this is your bridging vessels which we saw here, the bridging vessels, and the neovascularity of the bladder mucosa which is noted there. But what is again they have tried to report the same concepts by different terminology. The second terminology is separation sign. I demonstrated it right at the beginning. When you sweep through the placenta, you make sure that the placenta and the uterus slide, and when you give pressure to the myometrium and then release it, then it must go away and separate like this. If does not go away, then there is a very high possibility of PAS. So it simply means that the placenta is adherent to the uterus. I'm just demonstrating the same to you by means of the video. Can you see when I give the pressure here, the retroplacental space is not seen, and the moment I release the pressure, then you're able to see the placenta and the uterus go separate from each other, which they reported as a separation sign. It is a sign useful to know simply because of the fact that when you give too much pressure in a normal situation itself, then you might falsely think that the space is not there. So always give pressure and release. And the last sign that they reported recently is a pulsatile vessel at the posterior bladder wall, which is again a rehash of all the hypervascular or the neovascularization. The only concept is they're switching on the pulse wave Doppler. Why is that? Because the bladder varicosities are usually venous in nature. To differentiate, when you see this condition, you actually see an arterial flow there. So because you're seeing the arterial flow, you look at that point and switch on the pulse wave, you're able to see an arterial flow with a low RI, resistive index. And in this study, all the patients of this had this pulsatile vessel. So essentially, this recent Delphi study of the ultrasound signs gave us this concept. These 7 standard signs which I described at the beginning are what the Delphi consensus asks you to look for and report, and these are what are agreed upon by experts. The other additional signs and the novel signs have still been reported in this Delphi study as an addendum, where you cannot report the presence or absence of an adherence by the mere presence of these signs alone. But as I just showed you, quite a number of these potential or under quotes novel signs are basically caving the same wine in a new bottle and nothing more. I think it's getting late. I'll just finish with a minute's time to complete it. Will that be okay, madam?
Yes, please go ahead.
Yeah. So when you look at the first trimester, I'm just moving from the second trimester to the first trimester. Again, I'm going back to this recently published paper 3-4 years ago, where they looked at the comparison of the ultrasound descriptors of abnormal invasive placenta over the course of second and third trimester. 2 things they found. As I said earlier, the first trimester signs are already there, and the sensitivity is as good in the first trimester. But this paper also showed that these changes of the placenta are not too much as the pregnancy goes, which means if there is an adherent placenta, it is already adherent by the time of the second trimester, you are not going to have or less likely to have a placenta previa which is not adherent, showing no signs in the second trimester, to suddenly show new signs of adherence and invasion in late third trimester. So your best time to see is the first and second trimester and make a clarity of that. So this paper showed that the placentation process is completed in the middle of the second trimester. Further trophoblastic invasion does not take place, and both these published studies and this review clearly show absence of significant change across the trimester. So I go back from the second trimester to the first trimester, and it's nothing new. I'm actually trying to show the same signs which I showed you earlier. You can see that that's a dirty placenta with multiple lacunae, absence of this retroplacental space that is there. And I switch on the color flow, I can note the presence of hypervascularity there and the presence of bridging vessels there. So all these signs have already been there at this point of time. It's a very useful thing because in a patient, a decision making on pregnancy care can also be taken based on these signs at this point. As is noted in this case, we saw all these signs in the first trimester. Patient opted to follow up the pregnancy, and 25 weeks she ended up losing the uterus and the fetus because of a massive hemorrhage. So as I have reiterated in that prior systematic review, the signs that we see in the second trimester are all there at the 11 to 14 week scan, and the accuracy of these signs is almost as good as in the second trimester. The only thing that we are moving along is we are moving from the first trimester to the early pregnancy. In the early pregnancy, you don't see these signs. We look for specifically the presence of a low implanted gestational sac, and we look at the presence of this crossover sign, which is basically looking at the Caesarean scar. These two are the ones that we try to see at the 8-week scan. So what do we see in the early pregnancy? We look for the presence of a low implanted gestational sac. Many of the times when there is a low implanted gestational sac, it may be an inevitable abortion if it slides along. But in the setting of a prior cesarean, you look at the location of the sac in relation to the myometrium and the scar, for which you need to look at the cervico-isthmic complex. The cervico-isthmic complex basically involves the lower segment of the uterus, which is still not formed at this point. You have the isthmus of you have the cervical canal, you have the internal os, and you have the isthmic portion, and this is the circular echogenic structure that is there, and this combination is the cervico-isthmic complex. And what are you trying to look at? You're trying to look at the location of the scar above the cervico-isthmic complex or within the cervico-isthmic complex. And I have shown the same thing by means of a transvaginal scan and video, where I have given some amount of fluid in the bladder. I have gone through, seen the external os, internal os, and this is the lower end of the cervix, internal os. This portion is your cervico-isthmic complex. This is the Caesarean scar, prior scar there, that is seen as a hypoechoic area in this particular patient. So this scar is seen within this cervicostomy complex and not below the cervicostomy complex that is there. So the other thing in the early pregnancy is you need to look at when the low sac is there. I said you need to look at where the sac is there in relation to the Caesarean scar. This is you can see that in the rendered picture. This is the end on view. This is the cervix internal, or this is a myometrium. You are seeing the gestational sac in the anterior myometrium at the site of the lower segment scar actually bulging out, that is there. And you can see that in the transvaginal scan and video. And these are the ones which are at a highest risk factor for a adherent placenta. So when you look at the early pregnancy with respect to the scar, we look at the early pregnancy gestational sac inside the scar niche. I showed you how to look at the scar niche. So when the sac is low implanted and it is going inside the scar niche, as we saw in those pictures, then it is a early pregnancy Caesarean scar. The second thing is you see a early gestational sac It doesn't go inside.
Dr. Sudarshan, I'm afraid you will have to kind of
Stop
wind
here.
it up, please.
Yes,
Yeah,
yes,
yeah.
yes. I swipe to the last slide and then I wind it up, ma'am.
Right.
So
Thank you.
yeah. So I'll just wind up with this last slide. So when we look in the early part of the pregnancy, we look at this aspect where you look at the placenta invading inside the cesarean scar at the early part, and this you're able to document only if you document this whole cervicoischemic complex in the early part of the pregnancy. And if you document this, then it is a very high suspicion of PAS as you go on. I think I will stop because the time is getting delayed. Thank you so much.
Sorry, Dr. Sudarshan, but actually our time.
No, I completely understand. Yes, ma'am.
Yeah. Thank you. And I would like to tell all the friends that this detailed talk is available on Tuesdays with teachers as well. And so, Dr. Achala.
Dr. Achla, please invite Dr. Manju for her talk.
Invite Dr. Manju, who everybody knows, the president of NARCHI and a scintillating star of all gynae societies. And she's going to talk about a very important topic, guidelines, because without guidelines, we are nowhere. Placenta accreta spectrum is an emergency. We can lose the woman, we can have morbidity, but if we work according to guidelines, then we can probably save the patient, decrease the mortality and morbidity, and also save our skin in case of litigation. So over to you, Dr. Manju, for guidelines about management of PAS.
I think I'll share my slide. So, thank you, Dr. Achla, for the kind introduction. And after two very interesting talks, I now move on to the, PAS and review the existing guidelines. So whatever do we have in the guidelines? I know the guidelines, most of the guidelines came in 2018. And it is quite a number of years which have passed since, but still I thought let's review that. So we have the RCOG guidelines published in 2018 September. We had FIGU guidelines and they were published again in 2018. And we had the American College of Obstetricians and Gynecologists and Society of Maternal Fetal Medicine, again 2018. And this is by Ranzog that we have a very short guideline, and this is 2023. Additionally, I think what we have, which is very interesting, is that we have another guideline by, it is basically an article and it is from the FIGU, Committee of Childbirth and PPH, which talks about complex cesarean section, surgical approach to reduce the risk of intraoperative complications and postpartum hemorrhage. And it does refer to, it is not a pure guideline on PAS, but it gives us a lot of new understanding of things, which I will share and which subsequently Dr. Albaro and Dr. Saha are going to share with you. So I'm going to touch upon these aspects of, PAS management, antenatal diagnosis, place of care and type of health personnel involved, timing of delivery, type of anesthesia, surgical approach, role of conservative surgery, role of expectant management, and then hemostatic methods to reduce blood loss. So as far as the antenatal diagnosis is concerned, Dr. Sudarshan had given a very clear talk and cleared so many concepts. And it tells us that ultrasound should be the first line imaging modality for diagnosis of PAS and has comparable diagnostic accuracy, wider availability and relative affordability compared to MRI. So let's not jump on MRI as the first line. And that to grayscale. And put the Doppler only if you find the lacunae there. That is what Dr. Sudarshan said. And MRI should not be the preferred initial imaging modality. That is why. And it is important that the PAS is diagnosed and the diagnosis is confirmed by a specialist with skills in the diagnosis of PAS. And it also says that standardized definition should be used in reporting and consideration given to using a template, so that let's all of us have a similar template. And MRI may be used as an adjunct when ultrasound diagnosis is unclear. So this is the latest, guidance on that. As far as the place of care and type of healthcare professionals involved is concerned, we have a strong recommendation. Most of the recommendations are not very strong because you can't do RCTs for a PAS. So, it is more by case series and observational studies. So tertiary level facility is where we should operate and manage these patients, and by a multidisciplinary team. I need not go into the details of all these. So we need to have skilled people in all aspects. Then about the timing of delivery. So in the absence of risk factors for preterm delivery, in women with placenta accreta spectrum, planned delivery between 35 and 36 plus 6 weeks of gestation provides best balance between fetal maturity and the risk of unscheduled delivery. This is what the RCOG says, whereas ACOG, extends that window, and it says that any time between 34 weeks plus to 35 weeks to 6 to or 36 weeks completed, that is what 35 plus 7 or 36 weeks is what is done. So anytime after 34 weeks, we feel the lung maturity is there and we can go ahead. And the latest guideline says that timing of birth of women with suspected or confirmed PAS should be based on clinical grounds and the need to optimize fetal maturity, because we all understand that it has to be a planned surgery. So we can do it anytime between 37 to 34 to 37 weeks. Type of anesthesia. Choice of anesthetic technique for cesarean section for women with placenta accreta spectrum should be made by the anesthetist conducting the procedure in consultation with the woman prior to surgery. But what is important is we need to understand that, many people have started moving from regional, from GA to regional, because now there is a suggestion that we should do a bladder first approach, which you will learn subsequently. But RCOG says that the women should be informed that the surgical procedure can be performed safely with regional anesthesia, but should be advised that it may be necessary to convert it into general anesthesia if required, and she should be asked to consent for this. So whenever we do it under regional, we must take a consent for GA. What should be the surgical approach? Now, as far as the position is concerned, a dorsal lithotomy is preferred, a low dorsal lithotomy. Abdominal incision can be a midline vertical or wide transverse maillard or Cherney's incision. But the transverse incision would be there only if the placenta is lying only in the lower uterine segment and it is not encroaching on the upper uterine segment. Otherwise, a midline vertical is what is suggested. And uterine incision should be kept away from placental edge. It does not say you have to give a classical or you have to give a transfundal or you have to give transverse. It should be away from the placental edge. And it has to be a total hysterectomy with placenta in situ, without any attempt to remove the placenta. That is the most accepted approach, and no uterotonics to be administered. All the guidelines endorse this. And in case there is placenta accreta with extensive pelvic invasion is going to the parametrium, then delayed hysterectomy with placenta in situ may be considered. But it is a very weak, recommendation. Now, this is how the incision is given. But now more and more people, once you start thinking of conservative, you would like to give a transverse incision so that you can approach the low uterine segment. Now, as far as the status of conservative surgery is concerned, there is very limited, guidance on that. But it is said that when the extent of placenta accreta is limited in depth and surface area, that is, it is focal, and the entire placental implantation area is accessible and visualized, especially when it is on the anterior wall, it is on the fundus, or maybe a part posterior. Without deep pelvic invasion, uterine preserving surgery may be appropriate using partial myometrial resection. The guidance which is given by, Ranzog is that uterus preserving surgical technique should only be attempted by surgeons working in teams with appropriate expertise to manage such cases, and after appropriate counseling of the woman regarding the risk, benefits, and with informed consents. And conservative surgery should be considered only in carefully selected patients after detailed counseling and explaining them that this is investigational. So this is actually in 2018. So we do not have, guidance thereafter. So all the studies which are done thereafter would be discussed later. Expectant management, what is the status of that? That is leaving the placenta in situ. We know that all of us have left placenta in situ in some of our cases, but expectant management may be considered as an alternative to planned cesarean hysterectomy for appropriately counseled women who are willing to follow advice regarding the need for close surveillance. Because once you leave it in, there can be complications happening. And it is also said that services caring for women having expectant management must have the capacity to manage potential complications, including the need for emergency hysterectomy and emergency massive transfusion. And methotrexate is not recommended. Now, methods of reducing perioperative blood loss. So the routine use of interventional radiological techniques like embolization or placement of arterial, balloons to arrest arterial blood flow is not recommended. Its routine use is not recommended for women with PAS at the time of birth, because there are a lot of complications also associated with placement of these balloons. The role of bilateral internal artery ligation at the time of cesarean hysterectomy for PAS disorders is currently unclear. We all have seen that even if we do the internal artery ligation, the bleeding from the lower segment does not stop. Tranexamic acid should be administered 1 gram slowly, immediately prior to or during the cesarean delivery for PAS disorders. And there is insufficient evidence on which to make an evidence-based recommendation as to the use of uterine tamponade technique. So if the placenta gets separated, putting a Bakri balloon, we do not have evidence, but that works. That is what is the latest guideline. So a word about the messages which we get from this guideline, which is not actually for PAS, but it does introduces some new concepts. So the concept number 1 is, which Mitra has already touched upon, is the S2 segment. So the lower segment gets blood supply not only from the uterine, but it also gets blood supply from the vaginal artery, which is a branch of internal pudendal artery, which is a branch of posterior division of, internal iliac artery. So the blood supply to this segment comes from below upwards. So these are the azygous arteries where we need to focus upon, and that is what is new as far as the control of bleeding and doing conservative surgery is concerned. So concept number 2 is how do we achieve hemostasis? So achieving hemostasis by ligating these 3 vessels, which are colpouterine vessels and which supply, which actually irrigate the area where the placenta accreta is. So for this, to ligate these, we need to bring the bladder down. So bladder dissection is mandatory, and this works. This works in reducing the blood. And again, 2 new things which we normally don't practice is that even in placenta accreta, we can just put a Foley's catheter or a glove and tie it so that all these arteries get squeezed and the blood supply reduces. And then we can take some time and do our dissections. And same is true about doing a aortic compression, intraoperative aortic compression, because that is what is going to be very effective in reducing the blood supply rather than wasting time in doing internal iliac ligation. So that is the second concept. And the last concept is upfront bladder mobilization, that is even before delivering the baby, deciding whether we expose the anterior surface of the uterus, and Dr. Alvaro will go into the details. So this is what is the third very important concept, that you open it from the lateral side and take your fingers below the bladder by Pelosi's method and see, because the bladder is adherent to the scar. So if your fingers can go and there is no fibrosis, that means this patient is a good candidate wherein you can go in for conservative surgery. So to conclude, PAS is a challenging condition associated with increased maternal mortality and morbidity. The incidence of PAS is on the rise, and the patients with PAS must be diagnosed early in pregnancy and managed at a tertiary level center by a multidisciplinary team in a protocolized manner. So what you are going to learn today is how to follow a protocolized manner, a standardized, a method of care of managing these patients. The evidence regarding optimal management of PAS is insufficient and is evolving, and hence we need to be updated. Thank you so much for patient hearing, and we can now move on.
So I think that was excellent. And just before we invite the chairpersons of the first session to give their comments, may I actually welcome Dr. Parul Kotadawala. Sir has joined. We all know that he has been a very dynamic chairperson of ICOG. And I think to him is the credit to bring Dr. Jose to India way back I think maybe 17 years ago. Can we have Dr. Parul for a few minutes? Nilima?
Yes, ma'am.
And I think Dr. Manju, you are like Gagar mein Sagar. This was so very important and you have summarized everything so beautifully. And Dr. Bhaskar has sent his apologies because he's in the US with his children. Can we have Dr. Parul?
Yes. I'm here. Am I audible?
Yeah.
Yes.
So welcome,
Yeah,
Dr.
audible.
Parul. Thank you for joining.
Thank you. Thank you so much for asking me to be part of a topic which is very close to my heart. Because couple of us in Ahmedabad routinely keep on helping colleagues in distress with this issue. Just one correction I must make before I say anything more. Dr. Manjupuri just mentioned that vaginal artery is a branch of posterior division. That is not correct. In fact, it is branch of anterior division, and hence interiliac ligation perhaps is the most appropriate thing. Of course, the blood supply is so high that even if you ligate, it will not work always. But ligating the uterine is out of question because the vaginal artery and the vesical artery, these two will be escaping your ligation benefits. So that was just one correction. That interiliac, the vaginal artery and pudendal artery are branches of anterior division, and hence ligation of anterior division would be of some value. I'm not saying in all patients it will work, but it would be of value. Otherwise, of course, this topic is very, very diverse, and in spite of all guidelines, we do not have any clear-cut messages. Various options we can discuss, and in a given situation, we may use those. Okay. And I still think about that American College had identified centers of excellence for PAS, and they even recommended that by chance, if you open up and you find, because 30% of ultrasound and MRI also miss out PAS. And if that happens, and if you are not in a situation where you can handle it, close the abdomen, shift the patient to a center. And that S2 segment is very vital. Unfortunately, very few undertake this investigation. So S2 segment with MRI at around 28 to 30 weeks is very, very vital. And we should come out with ICOG or FOGSI guideline on this. And we should have a checklist that this is what you proceed with. I believe that Dr. Sheila will take the lead for that.
Yeah. So yeah,
Thank you
there
so
is a
much.
PAS registry which they are going to roll out. We are going to roll out. So I think
I'm
that
not
will be
talking
there.
of registry. I'm
No,
saying that
I understood. I
checklist
understood. I think, yes, all of us will have to come together, brainstorm, and then come out with these guidelines. Because why it is important, Dr. Parul? Because people still operate in a smaller nursing home. They
Exactly.
complicate the case, and then they shift the patient. So we have to come out with a clear some guidelines so that at least, even though we don't have center of excellence, but there are tertiary care centers where, I mean, all the facilities are available. So that will be better.
So, and one more thing.
Yeah, go ahead.
MRI, unfortunately, I am attached to the most advanced hospital in Gujarat. Zydus is the most well-equipped hospital. But our radiologists refuse to perform MRI of placenta previa. Placenta accreta. They say that we are not equipped, trained enough. Now, if that is happening in such an advanced hospital, you can realize what would happen in a peripheral area. So we need to catch hold of our radiologist colleagues also and propagate this thought that this is very vital, especially those radiologists who do cater to obstetric patients, that they need to take this up seriously because it is a life-saving situation or life-threatening situation. You can either. Thank you so much for asking me to be part of this.
Thank you, sir. And about the point that you've raised, Dr. Albaro is going to actually elaborate on
Can I,
this?
Mitra, comment?
Yeah, Manju, yeah,
Yeah.
please.
So, Dr. Paru, thank you for that comment. Actually, that is what we also believed. So, this is absolutely a recent new concept, which is actually given in the latest FIGO guidelines. You can look it up. But I'm sure Dr. Albaro will elaborate more on that. Yeah. So, this is a newer concept which has come up.
He has shared the link also, I think. He has
Yeah.
commented on the chat box, I think.
Because, I always used to do internal iliac ligation and follow it up with hysterectomy. That is what we all have been following. But this is slightly newer, so that is why we are keeping our minds open to understand what it is like, right?
So what would be the way out if that is so? We do not like it internally, and how do we take care of the bleeding?
So Dr. Alvaro will show it, Dr. Kudavala. He's going to show all those. Yeah.
Okay.
He will take us through that systematically, step by step. Yeah.
Fine.
Yeah. Thank you.
I think all the three speakers of the session were excellent. The introduction by Dr. Mitra and wonderful ultrasound pictures and explanation by Dr. Sudarshan really opened our eyes at how the ultrasound has to be done. It was very clear. And the guidelines and the newer insight into the guidelines, which I've also been reading, there has been a controversy regarding internal iliac. And it is believed now that better to compress the aorta and do the procedure than wasting time on internal iliac artery while you're doing the procedure. So I think excellent session. I really enjoyed it.
Thank you, Dr. Achla. I would like to thank Dr. Jogita and Dr. Arup Kumar Maji also for chairing this session, and our speakers, Dr. Mitra, Dr. Sudarshan, and Dr. Manjuburi. Now I hand over the next session to Dr. Nivedita.
Thank you, Dr. Renu. Moving in from a highly enthusing and engaging discussion of session 1, I take privilege to welcome 3 dynamic chairpersons of the session 2 who would effectively take us through the proceedings. CV of Dr. Yes, it's my pleasure to warmly welcome Dr. Rashmi Bagga. He's a professor at PGI Chandigarh, a prestigious institute of the nation. Madam is a clinician scholar with 300 publications to PubMed and a very high H-index, and she is integral part of the team which performs PAS surgeries of our institute. Next, Dr. Shashi Rekha. Yes, I humbly introduce Dr. Shashi Rekha, a very young professor at JIPMER, Pondicherry. She specializes in obstetric medicine, and she's been performing PAS surgeries for last 5 years without the use of internal artery ligation with minimal blood loss. Dr. Rashmi Bagga and Shashi Rekha have been part of the PAS immersive workshop that we had earlier this year. And Surekha Madam, CV please. Dr. Surekha. So we are immensely honored to welcome Dr. Surekha Tayade. She's an IVF consultant and ex-professor at MGIMS Wardha, ex-clinical research committee chairperson, and Madam has set a record of convening 26 good clinical practice recommendations in various topics in obstetric gynecology, which are non-inferior to RCOG guidelines in Indian context. Further, Madam has authored 10 books, and also she has contributed immensely to the WHO guidelines in PPH. So we welcome all the 3 chairpersons, and I request Dr. Bagga to introduce the first speaker.
Thank you, Dr. Nivedita, and thank you to Dr. Manju Puri and Dr. Mitra for organizing this ICOG workshop, and my namaste to all the ICOG executive members. So I would like to introduce Dr. Alvaro, and who has recently conducted a very great workshop, one of which I also attended, and revolutionized the concept of surgery in PAS. After that workshop, rather, we have been following his vascular anatomy insights and managed to do some conservative surgeries too, whereas earlier we might have done hysterectomies in those cases. So without any delay, Dr. Alvaro, please start your topic on vascular insights and newer concepts.
Good morning all. I think they will play a pre-recorded talk, yes?
Yes, sir. Okay. Welcome, Dr. Alvaro. Thank you for joining live as well. And
thank you so
you'll
much
be
for
here to answer a lot of questions.
Welcome, Dr. Alvaro.
Hi, friends. How are you? It's a big pleasure for me to be here with you. Thank you, Dr. Mitra. Thank you, Dr. Manju, for this kind invitation. I will start with the first talk. I hope to spend less than 15 minutes to have some time to comment, questions, discussion. And the first title is Vascular Anatomy, New Site. And this is very, very important to plan our approach for the postpartum hemorrhage control and to plan the surgical technique we will use for the treatment of placenta accreta spectrum. So, the uterus. This purple hypervascularized area in the anterior wall of the uterus receives blood supply from where? Our previous thinking is that the uterus is supplied by the uterine and the ovarian arteries. So I was taught this way. I was taught that 80% of the uterine blood supply comes from the uterine artery and 20% from the ovarian artery. But that is wrong because we are forgetting the lower pericle. And look how thick is the lower vaginal artery. This study from Dr. Palacios show that the vaginal artery in most of the patient is even thicker than the uterine artery and has a very complex anastomotic network and is very important for the blood supply in the lower part of the uterus. Of course, if you have a fundal placental, for example, in atony cases, the lower pericle is not so important. But if you have a placenta previa, look where is the usual topography or the placenta previa here. So this is exactly the area in which this hypervascularized area is placed. So the lower pericle is very important. Look how complex arterial is this arterial network, and the approach to this area is especially difficult because the proximity with the ureter and the narrowness of the space because of the bone pelvis. So this is a good example. This is a patient in which previous to this to start the surgery of the uterus, the PAS surgery, dissection, the surgeons perform bilateral uterine artery ligation and bilateral internal artery ligation. And even having those ligatures, look how heavy is the bleeding. What is happening this? Because of the bleeding is coming from the lower pericle. So this is not really new. Look, this is a diagram from the 18th century. And look how thick is the the vaginal artery. And look how it is coming from the posterior branch of the internal iliac artery. So in some moment, we lost this information and we copy the wrong information from some patient in which the internal pulmonary artery arises from the posterior division of the internal iliac artery. So we have this lower area in the uterus that receive blood supply mainly from the lower pericles, uterine artery, and we have this uterine body and uterine fundus that receive the blood supply mainly from the uterine artery. So we are very used to handle this, but we struggle when we face this bleeding from this area. So I was teach this way. I was teach under most of the books that describe that the pudendal artery arises from the same branch, same trunk that give the uterine artery. And I was teach also that the uterine artery has a very thick descendant branch to the cervix. And that is not right, I will show you. Because really, the posterior branch of the internal artery give the inferior vaginal artery. So it is not really a descendant branch from the uterine artery, it is really an ascending branch that is called colpouterine artery, and that changed everything because when you ligate the uterine artery, you are not controlling bleeding from the lower part of the uterus. That is the reason a lot of studies, research conclude that bleeding because of placenta previa or because of placenta accreta spectrum is not really controlled when you clamp the uterine artery or the anterior branch of the iliac, the internal iliac artery. Okay. Now we know the real source of blood supply from the lower uterine, lower part of the uterus, lower uterine segment and cervix. But we need to also focus on the surgical technique to approach this area. And this dotted yellow line marks the area in which usually we found the vesicouterine peritoneal fold. So below this area is the tricky part, because we are not really used to handle this. Most of us were taught for an hysterectomy, pulling the uterine and putting the clamps very close to the uterine, because somewhere in the sides of the pelvis you will find the ureter. Of course, our gynecologist, our friends, gynecologists and the pelvic surgeons are used to identify the surgery, but not most of the general obstetrician. So this is a unknown or not really widely known anatomy. This is a tricky area, and we are not used to work in this area. Okay, this is a curved dissection in which you will find the fundus here and the vaginal wall here. And this is the colpouterine arteries that go up. This is after dissecting half of the vaginal wall. And look how the left midline and right colpouterine arteries rise and anastomose with the uterine arteries. Look how thick it is. It's not a very small branch, and this is not a pregnant patient. So what happens if you have a pregnant patient with a placenta previa that produce growth factor? These vessels enlarge a lot. And this is during a C-section. This is the round ligament, this is the uterine artery, and look how thick is the colpouterine artery. In this case, was very evident. That's the reason we recorded. Most of the cases, it's not as evident at this case. And look, when we squish it, it's filled from below to the upper part. So it's not a descending branch. It's an ascendant artery that is called colpouterine artery. Most of the cases it's not easy, not as easy in this case to identify it, but you can do it. And some cases is very, very clear. I know that most of you remember in the anatomic books, the ICOG vaginal artery described in the midline of the uterine wall, rising and reaching the lower uterine segment. It is really the midline colpouterine arteries, and you will find another in the right and another in the left. Okay, so we know that that the lower uterine segment receives blood supply from the colpouterine arteries, but that is not enough, because we need to consider that this is a very complex anastomotic system in the pelvis. It's even more, has more anastomosis than the brain. And for that reason, if you occlude one small distal branch, you will have a collateral flow that fill the distal arteries. That is what happened when you occlude the anterior branch of the internal iliac artery. You will have the distal reperfusion by collaterals. And why we still use internal iliac artery ligation in most of our countries? Because most common procedure for bleeding in PAS. And this is the history. Remember, we were taught that Dr. Kelly was the first one, but not really. We have two more authors before Dr. Kelly. But okay, it can work for atony, because anterior trunk give uterine artery, and uterine artery give most of the blood supply from the uterine body and fundus, but not for placenta previa. We have a lot of studies till in the 80s, in the 70s, Dr. Bolches performed a lot of studies that conclude that it's not usual. It's only the only effect is decrease the blood pressure, but temporarily, because then you will have a reperfusion from the collaterals. So in 1979, most of the people stopped using it, but then in 2000, with the use of balloons, this technique about occluding endovascular, the anterior branch of the uterine artery, gain attention again. But we need to remember it's not useful because of anatomy and has risk, because remember, most of the bad results are never published because of the legal issue, and because we always prefer not to talk about the maternal deaths and the complication, but there are a lot of problems. Remember, the urologists also use this for the prostatic surgery in the past. They stopped using it after these studies I show you in the 80s, but there are reports of deaths because of tearing the vein, because the problem is not the artery, the problem is the vein is behind and is very, very close. And when you are trying to passing below the artery, you can tear the vein, and it is very complex to repair. So how to control the bleeding for the lower uterine segment and this complex arterial network in this very narrow space? Keeping the thing simple, the best way is to occluding the aorta, and you can do it by hand, compressing, or you can do it, of course, if you have surgeon, you can put a clamp, or you can put a balloon, but it's the same as using your hand. And you will be controlling S1 sector, that is the fundus, S2 sector, that is the lower uterine segment, and also S3 sector, that is the upper tier of the vagina. Because not all the placenta accreta spectrum are the same, and not all the patients need this complex arterial procedure. How to identify which patient need it? By anatomy. So lesion in the upper part, most of the cases don't really need this aortic control, but lesion in the lower part, especially those in the lateral part bulging to the parametrium, really need it. But why we still find scientific papers and books that describe that the pudendal artery that give the vaginal artery arise from the anterior division? Because that happened in some patients, and this is a big meta-analysis. Look how much cases, for nearly 5,000 patients analyzed, and they found that in most of the cases, 60% of the cases, the internal pudendal artery arises from the posterior division. That is the most of the cases. Some cases, only 19% of the cases, can arise from the anterior division. So this is the most common pattern, a pudendal artery arising from the posterior division. So when we ligate only the anterior division, we are leaving open the pudendal artery, internal pudendal artery, the inferior vaginal artery, and the colpoid uterine artery. So you can control the uterine artery and bleeding from the fundus and the body of the uterus, but not bleeding from placenta previa. So only 13 to 19% of the cases, these branches to the lower uterine segment arise from the anterior division, and this is the cause of the confusion. So we need to be clear now. That is a very, very few patients. So if you try to ligate only the anterior division of the internal artery, you will do nothing for the bleeding of the placenta previa. And it's all about anatomy. So for keeping simple, if the bleeding is from the fundus, you can just place a tourniquet or ligate the uterine artery, and it's really easy. But if you are dealing with bleeding from the S2 sector, the lower part of the uterus, you really need to dissect the bladder and to control the colpoid uterine arteries. This is a widely interconnected system in the pelvis. So we need to keep these simple things in mind, not memorize it, all the names of the arteries, on the branches and the division, no. If you have bleeding from the fundus, it's easy, place a tourniquet and do whatever you want, compressive suture, ligate the uterine artery, or placing a balloon. But if you have bleeding from the lower part of the uterus and the cervix, you really need to dissect the bladder, and you need to deal with the cold uterine arteries. And you can place also a compressive suture, but that is designed for this lower part, like Hocho and Balinch transverse. But if you are in a hurry, if you are heavy problems, if you are having heavy bleeding, you just compress the aorta, occlude the aorta, and control all the source of bleeding. Thank you so much.
That was a lucid elaboration. And already I spoke about Dr. Shashirekha. So it's like something like experience meets evidence. With this, we go to the second talk. And for that, I request Dr. Shashirekha to do the honors and invite sir.
Good evening, everyone. And thank you so much for the opportunity, ma'am. It's a privilege to be part of this session. And we had the opportunity of attending Dr. Alvaro's session with hands-on session of ligating the colpouterine branches. It's very important to do this meticulously to dissect the bladder. Aptly put, the key to the open the lock of surgery in placenta accreta spectrum is dissecting the bladder. Because many times what we do when we just try to ligate one of the vessels becomes sort of messy, and we end up in doing the surgery very fast. Actually, what is required is unhurried, meticulous dissection of those vessels. And also the bladder dissection, as Dr. Alvaro described, especially in those with the lower segment placenta accreta spectrum. So to do this, we have the app person, Dr. Pradeep Masaha, who is a professor. Can we have the CV on the screen? Dr. Pradeep Kumar Saha is a professor in PGI Chandigarh, and he's also the president of AGOI Chandigarh chapter, who has introduced the concept of bladder dissecting the bladder first. Though controversial, it's probably the world is slowly accepting it. And we also got convinced with Dr. Alvaro's hands-on workshop on how to dissect the bladder first and then do the surgery. So it's all yours, sir. We invite Dr. Saha, sir, to give this deliberation on dissecting the bladder.
Thank you, ma'am. Good evening, everyone. Thank you for kind introductions. I would like to thank Dr. Manju, ma'am, Dr. Mitra, ma'am, for giving me this opportunity to speak on the topic that is very close to my heart. So that is the bladder first approach for hysterectomy for placenta accreta spectrum. Even also it is important for the one-step conservative surgery. So initially we practiced several other approach, but over a period of time, we realized that this is one of the best approach. It does not mean that this is the only approach. There can be many other approach as well. When I met Dr. Alvaro and Dr. Jose in last meeting, and I observed that they also, they have the similar kind of concept and similar kind of ideas. So this convergence of surgical strategy that reinforce the conceptual, the validity and the importance of this particular approach. In my talk, I will discuss about the principle of this that bladder first approach, what is the rationale behind it, and the steps of the procedure, and I will show some videos and the other studies, and of course our experience from PGI. I especially thanks Dr. SP ma'am for chairing this session as well, because she also has contributed significantly for bladder first approach. So just to highlight that the disease burden faced by us in PGI, since 2016, we have almost performed 500 hysterectomy for placenta accreta spectrum. Maximum it was in 2024, and last year it was 70. It does not mean that the incidence has reduced. It means that a lot of patients now we are doing the conservative approach. That's why this is only the details of the patient who actually require hysterectomy. I think this has already been discussed, that this kind of patient should be managed by multidisciplinary approach, and it should be in a tertiary care center with specialized all disciplines like radiologists, hematologists, blood bank, and all intervention arm of the radiologist. So everything has to be there. then only that complication can be reduced. And data also suggests that one should do the elective surgery rather than emergency surgery because there are more complications, more blood loss. There are different surgical approach. If you look at the article, what we follow is either primary cesarean hysterectomy or one-step conservative approach. So what is the bladder first approach? So before I go through the details of this approach, I would like to mention some of the things which is very important because we practice and it is part of our protocol. So this is the Placenta Accreta score. I think in previous lecture, we have understood that there is some grayscale features as well as some Doppler features. So if you see all these features, that every feature has its own sensitivity and specificity. And these features, that ultrasound features, Doppler features, as well as with some kind clinical features that where the placenta is. So based on this, one can assign the score on a particular patient. This study has been performed in PGI. And what we have understood that if the score is less than 10, then one can think about the uterine fissure surgery. If the score is more than less than 10, then it's a conservative surgery. If it is more than 10, then most probably patient will require hysterectomy. If the score is more than 15, 16, then one can have a very difficult surgery or maybe patient can have a complication post-op. So this is how you can counsel and can prepare your resources as well. One of the very important things which I mentioned, because this is a complex surgeries, you need multidisciplinary team, and it has been mentioned in different literature that one should have a checklist. It is very important, otherwise you're going to forget so many things. So institute who manage this kind of patient, they should have their own checklist depending on the resource availability. So I'm not going details. So approach we follow, earlier we used to give the general anesthesia. However, nowadays we prefer the spinal and epidural. We always prefer vertical incision, vertical midline incision, skin incision, and we dissect the bladder flap before delivery of the baby. And you give the classical uterine incision if you feel that patient will require hysterectomy. Otherwise, you can, if the score is less, you can give transverse incision also in the lower segment above the placental attachment. And no attempt after delivery of the baby, no attempt is made to remove the placenta. If the placenta, removes on its own, it is fine. One should proceed with, hysterectomy with placenta in situ. So what is the principle of bladder first approach? It is just to achieve the vascular control of the collateral circulation. If you look at this, intraoperative findings, there are multiple vessels which is traversing between the lower uterine segment and the uterus, and you have to ligate this vessel before ligating the main uterine arteries. So what is the rationale behind this principle? This approach we actually follow. So what we have understood from our previous experience, there are troublesome bleeding which continues to occur from the bladder surface, mainly from the blood vessels which are traversing between the bladder and uterus. This is really large area of continuous oozing, which is difficult to control and results in significant hemorrhage. So dissection of bladder in a controlled situation in an unhurried and calm manner, ligating these vessels prevent hemorrhage. It also reduces the bladder and ureteric injury. See, if the bladder injury happens, then you need extra half an hour or 45 minutes time. So that time patient will bleed. So what is the steps of this approach? We always do preoperative ultrasound mapping of the placenta to find out what those we give the, we have to plan our incision. And after giving, we give the midline vertical incision and the skin incision. And that is the most important thing, is that bladder has to be kept partially filled with 3-way Foley's catheter to delineate the superior limit of the lower. It is very, very important thing. So instead of just putting a simple Foley's catheter, one can use the 3-way Foley's. So you have to do the emptying and filling the bladder. That is very, very important. And then dissection of the bladder is made round to the cervix. So I'll just go through my videos. Yeah. First one. So this patient, she had a previous 3 cesarean section. It was elective peripartum hysterectomy, and we did the hysterectomy at 35 weeks period of gestation, 35 plus 4 weeks, because it was very, the score was very high. So just give me the mouse, please. So you can see that after opening the abdomen, that placenta is almost coming out, and there is a.
We can't see the video.
The video is not visible.
Oh,
Please unshare and then share. I think then maybe.
Please close this presentation. Go to your desktop and. Yes.
Is it visible, ma'am?
Yes, yes.
Perfect.
Okay. Sorry for the first problem. So you can see this is the bladder, and it is partially filled bladder, and which is held with the the Babcock's. It is very important, and you can see this vessel is the bridging vessels, which are basically traversing between the lower uterine segment and the bladder. So initially it looks like that it's very difficult to separate, but yes, you have to be very calm, and you have to very very gentle when you are dealing this kind of vessels, because these vessels are neovascularized, so they are devoid of tunica media, and that cooperative coagulation, specifically the monopolar cautery, it may not work, but bipolar cautery, yes. But if the vessels is large, like in this particular case, it is quite big, so we are basically ligating both the side, and we are cutting in between. So we use the 2-0 seal suture, but you can use any kind of suture, vicryl, but it is easily available, low cost also. So another vessels, you have to make a small nick over here, and then pass on the artery forceps, then take the vicryl on both, that seal on both the side, then you ligate. You have to be very careful, although this vessel sometimes looks like very small, but if these vessels are injured, they bleed a lot. So then on the opposite side also, you have to tie it, and then you cut in between, so that we are basically opening the UV fold. So only if the bladder is filled, then only you will be able to make out where the bladder at the superior limit of the bladder. That is very, very important. So again, there are another vessels. You can see that there are some bleeding, it can happen, but most of the time, if there is a bleeding, you just press a sponge over there, and it usually stops after 2 to 3 minutes. It usually stops. So you can go on other area, and then you can again come back. So that you can do. So again, there are vessels, similar way, we are ligating both the side, and then so one has to be very careful when you are basically dissecting these vessels, and you are basically dissecting the UV fold, because sometimes there is no myometrum at all. So what happened that initially, that inadvertently you can go inside, but over a period of, once you are used to this, then probably you will be able to know that how much pressure you should exert. That is important. So this is on left side of the UV fold. When you are going lateral, this is one of the difficult one, because according to the figure staging, this is 3C. It is going into the parametria on left side. So again, this vessel is going into the parametria. Again, you need to ligate both the side of these vessels. So now sometimes it is asked that why you can't separate. You can't do after delivery of the baby, but it's very difficult. See, if you have again, we are going laterally, and you can see over there that left side round ligament is also very vascular. Yes, there is a bleeding actually, but usually stops most of the time. So again, we are this on right side. So UV fold is already open, but still it is not separated much. It is not separated much. So most of the time when you are basically separating this UV fold, it takes time. Specifically, if it is like this kind of case, it may take 45 minutes to 1 hour even. But this is the earlier videos. So at that time we used to, we basically use the silk suture. But nowadays we are using bipolar also if it is small vessels. It works. It works. So UV fold is, you can see that UV fold is open. Sometimes what happens that if you are not able to separate the bladder from midline, then you should go from lateral to medial. In that condition, you have to cut open the round ligament, and then open the leaf of the broad ligament, anterior and posterior, then come from lateral to medial. That is important. So, when you are doing this particular, approach or particular procedure, you need to ligate multiple vessels. So in earlier days, we used to do the ultrasonography also during this procedure because it takes time. So although it is elective surgeries, after doing 60-70 cases, we stopped doing because it doesn't make any difference. And since patient is under regional anesthesia, they are not much worried. Though in our study, when we had earlier, we used to give general anesthesia, then also there is not much different. So you can see that bladder is separated to some extent. Yeah. So if there is a previous 2 or 3 cesarean, you may face difficulties at different level if the scar is at different site. So that is also important. So this is the small vessels, but still we ligate it with the silk suture. So there was a bleeding. This on right side. This is the right round ligament, right side. Should I do fast forward, ma'am?
I think you can, Dr. Saha.
Okay, ma'am. I must respect the time. So now we have delivered the baby by classical incision. So I just fast forward this. Yeah. Now we are taking care of the tubo-ovarian ligament, tubo-ovarian structures. So this is the regular steps. If patient is not bleeding, you can be slow. Otherwise, you have to be a little fast. You can see that placenta is bulging because there is no myometrium at all in this particular place. So this is right side. Yeah. So after this step, you have to find out the ureter because the ureter can be dilated. It's very easy to identify the ureter specifically in obstetric cases. Most of the time they will be dilated. So there can be many other vessels also. Not that main uterines, but there can be other vessels. So we have almost we are basically taking care of the uterines. I have to fast forward. Yeah, so it is not necessary to go up to the vagina. I mean, it's not required to remove the whole cervix. We always prefer the subtotal hysterectomy. The reason being, I mean, you have to just complete what the placenta is actually ends. That is basically the end point. Yeah, it is just where specimen is going to be out now. Yeah, now specimen also you have to take the and we in our experience that placenta usually it doesn't invade the the cervix beyond internal os. So you have to check everything, all the pedicles, ureter as well, and you must reinforce the all pedicle. Next video, please. Yeah, next one. Stop. Then next video. So this is relatively new videos where you have used bipolar. So apparently it looks like very angry looking. This is one of the very, very difficult cases. So you can see that initially it looks like the placenta, you can't separate the bladder. But yes, it is. Once the bladder is filled, you'll be able to make up. What is the superior limit of the bladder? So these vessels are quite big. So we are basically ligating on both the sides. So if you deliver the baby fast, then what will happen that hysterectomy site can bleed, or the placenta can be partially separated. Then also it can bleed, or your incision also can involve the placenta. Another most important thing, which most of us believe, that if you do not separate the bladder, it is very difficult to make out what is actually happening below, because sometimes it can be. We are actually using bipolar. In this particular case, this vessel is quite big one. So we'll ligate with silk, 2-0 silk on both sides. There are small bleeder is there. So we are just put the sponges or can use the gauze as well.
Yeah. Dr. Saha, you can just forward it to show after the resection is completed now.
Okay.
Yes.
I think Dr. Rashmi,
yes,
we have to go with very, very important talks of Dr. Albaro, the
Right,
surgical
right.
staging of PAS
Right.
and the other two procedures. So they are
Right.
actually, he's going to cover all that.
Right.
So, I think that is.
Yes, because
Yeah,
this
if you don't mind.
actually what like Dr. Saha has shown very nicely. Initially, when we started, we were using ligation with silk, and then with the use of bipolar, we started testing bipolar at least on the other side, and then slowly we at least 80% can be done with bipolar, 20% the big ones we use silk. That
Yeah,
saves
so-
a lot of time. And
Yeah.
I've shared articles in the chat about the safety of GA.
Thank you, Dr. Rashmi.
Yeah, GA is not the preferred one. Epidural is the preferred one. But when you start initially, the anesthetist is also wary of the surgeon. And so they prefer GA because they have a better control. So slowly when they feel that the surgeon can do it with less blood loss, then they started doing with epidural, which we are now moving on to. And yes, yeah.
This is the partially filled bladder, which is the whole held with this thing.
One is the partially filled bladder helps to delineate its upper limit. Because of the vascularity, sometimes the upper limit may not be there. The flattened bladder can easily be cut, thinking this is the peritoneum. The second thing is there that when the bladder is filled and the uterus is filled, so there are two spheres. So the interface between two spheres, wherever there is no adhesion, that tends to show up and separate. So that helps in aiding dissection, that you have adhesions and the area of adhesions gets demarcated, and somewhere where there is none, that also becomes demarcated.
Mitra, I think we need to move further because
Yes.
Okay, right.
Short of time, right?
Right. So I will just.
Thank you, Dr. Saha, so much.
So basically, Dr.
Rest
Saha,
of
we
the-
wanted you to show us the bladder dissection. So how
Yes.
to go about? I think that we
Yes.
got a fair idea of how to
Right.
go.
Okay, I'm just now going back to my slide.
In fact, Dr. Manju, the concept which you touched upon about the vascular supply,
Yeah.
and then Dr. Parul Kotwala pointed it out, that is really the key now. And I'm glad he pointed it out because that's what
Yeah.
we
Yes, I
reinforce.
fully agree.
And Dr. Albaro has shown beautifully that 80% of supply comes from posterior one. And actually, if you ligate the anterior division,
You can find the difference.
will increase.
हाँ
So,
जी,
and we have felt that we have ligated the anterior division, कोई फायदा नहीं हुआ.
exactly.
कोई फायदा नहीं हुआ. So, इसका रीजन हमें अब समझ आया है फायदा क्यों नहीं हुआ, क्योंकि posterior का ब्लड फ्लो बढ़ गया था. उससे तो anterior division ना ligate करते, the blood flow was less.
So,
I think we can move on to the next talk as well.
So initially we published the 12, cases, and none of the patient had bladder injury, and none of the patient required ICU care, and blood loss was around 1.5.
Right.
So subsequently, one of the largest series published in the American Journal, and if you see the blood loss initially was 1.5 liter, but later on it is 1.2 liter. Maybe that we have gained experience, and there are many per capita patients who did not require blood transfusion at all. That is very, very important, and only 3 patients had bladder injury, and 3 had ICU admission. Yes. So this is the details of the paper. You can go through it. It's a open access journal, so open access article, so you can get easily. So what Madam has said, that this is very, very important, that partially filled bladder is important. Actually, what happens, suppose if your bladder is not separated and there is a bleeding, you are in hurry. And when you are in hurry, you are going to take suture here and there. You don't know where it is, what is going on. And then you make the bladder injury. And once the bladder injury happens, it applies to me also. I try to justify that. So it may not that the placenta is going inside the bladder, specifically beyond the seromuscular layer. We haven't seen as of now that placental tissue is going into the mucosa.
Right, Dr. Saha. So the point is very well conveyed. We can now move on to the next talk.
Excellent talk.
Thank you, Dr. Saha. Thank you.
Thank you.
So Rekha ma'am, if you could reintroduce Dr. Albaro on his talk.
Or the
I
topic.
am not able to. Hello, am I audible?
Yes, ma'am. Yes, welcome. Ma'am.
So I think
Thank you very much to ICOG and to the organizing team for giving me this honor of chairing the session of Dr. Albaro. Dr. Albaro, I would like to just share with you that we had an opportunity to meet Dr. Maria Escobar. She had come to MJMS Sevagram, which is my place, and also during the WHO guideline development for PPH. So I know your place from Kali very, very well. And congratulations for all the work you have done. And I'm chairing this session, which talks about the placenta accreta staging, the PAS staging. And we all know that historically, the PAS used to be staged by histopathological depth of invasion. Like we used to say placenta accreta, increta, percreta, and that used to be managed intraoperatively using, standardized surgical systems. But this staging used to be complete only after the hysterectomy was done. So naturally now, because we want some staging which can be done intraoperative, when we look at the uterus, when we look at the vessels, and we look at the how much invasion is there, that kind of staging is very important to decide whether we are going to go for a conservative approach or whether we are going to go for a radical hysterectomy type of approach. So this kind of staging has come up and from FIGO, and it has been published very recently. So definitely we would like to know from Dr. Albaro about this clinical staging and especially that intraoperative staging of PAS. Thank you very much for being here, and the stage is yours.
Hello, how are you? I hope you're enjoying this meeting. And let's talk now about the surgical staging. And it's impossible to talk about this without addressing the topographic classification for placenta accreta spectrum. So what is the idea? The idea is to individualize the treatment. And we have mainly 3 treatment options. The most widely used is hysterectomy. We have this placenta in situ techniques from the French people, and we have several techniques for uterine sparing surgery. The most well described and the one with the biggest evidence is one-step conservative surgery. Each technique has its own advantage and also its own problems, and it is not one technique for all the patients. That is not something like the best option. You need to individualize the treatment based on the clinical scenario, your skills, and the viability of the resources. So please, first of all, never take decision only with the first view of laparotomy, because sometimes we can see a very small area of abnormality with a big problem below the peritoneal reflection, just like in this iceberg image, or even sometimes it is normal because the first local laparotomy is normal because the problem is below the peritoneal reflection and you need to dissect the bladder to watch it. And sometimes also, as we are putting in this diagram in the right, you can have a big, ugly medusa head appearance in the anterior lower uterine segment, but after dissecting not too much bladder, you found healthy tissue below. So this is the topographic classification in the left and lateral view, and in the right frontal view of the uterus and the bladder. And each one of these purple circles represents one of the topographies. So type 1 is upper anterior lesion. This is the more common place for the accreta because this is the place where we used to perform the C-section. And it is not so difficult to deal with because you will need to dissect the bladder, but you will find healthy tissue below. But the problem is when the lesions are below this dotted line that represents the peritoneal reflection, and when it is happening in the anterior wall, this is called type 3, and if you cannot dissect the bladder, it is called type 4. And you can have also lower posterior lesion and lateral lower lesion. This lower part of the uterus, the lower uterine segment and the cervix, is called S2 sector and receive blood supply mainly from subperitoneal branches called colpouterine arteries that are branches from the posterior pudendal artery and the posterior division of the internal iliac artery. So what is surgical staging? Surgical staging is dissecting the bladder, exposing the anterior and lateral wall of the uterus before taking the decision regarding the treatment. So first step is to pull the wrong ligament, cut the anterior shear of the broad ligament, opening this parametrial space with your fingers, then moving your fingers down to the medial paravesical space, and then approaching bilateral, filling the retrovesical space. This is the Pelosi maneuver to feel if you have fibrotic tissue there, dense adhesion between the bladder and the uterus. The third step is to pull gently 45 degrees from the horizontal the bladder and dissect one by one the vesicouterine arterial pericles. And after delivering the baby, externalizing the uterus and check the posterior wall of the uterus. This way, you will be sure about the topography of the lesion. This is which of the uterine wall is affected. And you can apply the topographic classification that is based on what uterine wall is affected, if the bladder is can be dissected or not, if the lesion is above or below the peritoneal reflection, and based on that, you can define what arterial pericles are involved and how difficult the surgery will be. So in the left, you are seeing the different numbers. It's not necessary you to memorize it because the numbers are not really important. You can just describe anterior, upper anterior, lower, upper or lower, lateral, upper or lower. The type 3 is the anterior or lower. The type 4 is the same, anterior lower, but in which cases in which you cannot dissect the bladder. And the type 5 are the posterior lesion. And I like to explain this asking the people to imagine the fibroids. Because if you have a big fibroid in the fundus, even being very ugly, it's not a problem for any obstetrician because the lower part is free and you can dissect safely and easily. But if you have a 4 centimeters fibroids here, lateral lower, it's very difficult, even being smaller, because in this topography, you have a very narrow space because of the bone pelvis, and you will have very close the ureter and some big vessels. So when you dissect the bladder and mobilize all the tissue exposing the lateral anterior wall of the uterus, you ask your team these three questions. It is possible to dissect the bladder from the uterus, yes or not? It is at least 2 centimeters of healthy tissue below the bulging area, yes or not? And have you more than 50% of the uterine circumference with healthy tissue, yes or not? If your answer to this question is yes, this patient is a good candidate for focal resection. This is one-step conservative surgery. Fortunately, this is the situation for most of the patients because this is the area in which we used to perform our previous section and where the myometrial defects are in the most of the patient. This is a good example. We already delivered the baby. Look, the clamping of the borders of the hysterectomy, and after clamping and dissecting, after ligating the colputerine vessels, it's easy to identify the normal tissue below the bulging. So we have more than 2 centimeters. We have more than half of the circumference of the uterus with healthy tissue, and this is a very good candidate for focal resection. Look how the posterior wall is healthy. And we are sparing the uterine artery because it's not necessary to ligate it. But some cases are very different. For example, cases in the lower part, because this you will find here in the deep of the pelvis a very complex arterial network, and for that reason, focal resection is not for all the cases, and these cases need total hysterectomy. Let me reject this call. For example, this case is a anterior lower bulging. Look how lower is the bulging reaching the cervix, and even having a normal posterior wall of the uterus, you have this this case in which is not a good option to try to do a focal resection because you have not enough healthy tissue in the lower part. And the most severe cases are two types. Two lateral, this is low lateral because the lateral bulging will compress the parametric structures and will be very difficult to isolate the ureter, and also this type 4 in which you cannot dissect the bladder because you will have this concrete-like dense addition in which if you try and keep trying to dissect the bladder, you will tear the bladder or the capsule of the bulging area. So this is not a new classification. Indeed, this has more than 10 years been evaluated. You will have a lot of papers documenting the characteristic of each type of the lesion and why this is useful. Even we have randomized control trial comparing one-step conservative surgery versus hysterectomy using the topographic classification. So you don't need to memorize it, but each topography has a different profile of vascular blood supply. And for that reason, each topography has a recommended vascular procedure. For example, this is a type 1. Look how the bulging ends here, and in the lower part, you will identify healthy tissue. So after removing this area, you reconstruct the uterus, and you will have a not so difficult surgery. But lateral lesions are not as easy to treat. For example, this is a case in which it's better to go directly to total hysterectomy or maybe to do a focal resection. But in this case, it is necessary to ligate the uterine artery in this side. This is a low lateral lesion. This is the posterior view, and this is the ureter. And look how close is the bulging area with the placenta and normally attached over this trajectory of the ureter. So this is a very, very complex case, and you will need definitely to have a very effective vascular control strategy. This is a type 3, lower anterior, but sometimes lower anterior has enough healthy tissue to think in reconstruct. A very good option is to place a tourniquet, try it, and if it doesn't work, you move to total hysterectomy, but sometimes work, like in this case. But this is a very massive bulging with not enough healthy tissue, so please don't try it because you will have heavy bleeding and probably you will fail trying to do focal resection because you have a big bulging here. This is a type 4 in which you found this dense addition, concrete-like addition like fibrotic tissue that make very difficult to keep dissecting the bladder. And if you keep trying, you will tear the bladder or the capsule. And this is a posterior lesion in which there are some specific anatomical feature in which this area can receive blood supply from the branches of the inferior mesenteric artery. So the vascular approach, the bleeding control approach is quite different in these cases. I know that we are used to do the same for the patient because we were teach that way regarding Accreta. Always midline, always fundal extraction, always closing and go direct to hysterectomy, using a lot of resources, cell saver, urethral stent, vascular procedure, but you have the experience dealing with this. So it's just about changing a little. And I know that that is the most difficult. Changing is the most difficult thing for adults, especially for surgeons, because we become used to something, we master it, and we want to keep doing the same, even if sometimes the results are not as good as we wish. So changing is difficult, but it is possible, and it's easier if we collaborate, because this is a very good paper saying that it takes more than 10, or in this case, 17 years from a good paper is published, high quality evidence is published, till the general population receive this technique of this technology. 17 years. How to shorten this time? Working together and collaborating. For that reason, I invite you to participate in this multi-center, multi-core prospective study. We are evaluating in a multi-center way this topographic classification and this surgical staging procedure. We will have two objectives: evaluate the correlation between the topographic classification and the clinical result, and also evaluate how difficult to use it is. I mean, how acceptable this topographic classification is. We expect to include 350 patients, and we have a lot of supervision here and also a lot of help. But the most beautiful thing is that a lot of people around the world is helping us, is participating us. We held more than 6 months of meetings in 2024, and now we have more than 50 hospitals in 12 countries participating. We already published the preliminary result of this research. And look how different categories, type 0, type 1, type 2 upper, type 2 lower, type 3, has different features. As I told you, type 4, those patients with fibrosis has the higher blood loss volume and the higher risk of bladder tears. And look how upper anterior lesion has the most frequent success when you try focal resection. So transfusion is the same. Parametrial, I mean lateral lesion, and type 4 or anterior lower has the most higher frequency of transfusion. So each category has its own characteristics, its own profile, its own phenotype. And it is the same. This was 44 patients published last year. And now we have more than 200 patients, and the results are the same. I mean, the tendency, the profile is the same. So this is not anymore a research topic, an experimental issue, not anymore. And this is very important, because when you try to apply the topographic classification using ultrasound, you have a linear correlation with the intraoperative staging. I mean, if your sonographer, after some training, of course, say that this is the type 3, believe him or her, because it's surgical, it is very probable that during surgery you found that. And if your sonologist say that this is an upper anterior lesion and you will be able to do focal resection, you have a lot of probability that that is right. So we need to individualize the treatment. It's not anymore about doing hysterectomy for the patient, and surgical staging is the most safer way to do it, because there is not something like an ideal treatment for the patient. We really need to adopt new techniques, and if you are in a reference center for PA, you must handle it, all the treatment options. Thank you so much.
Thank you very much.
Thank you, Dr. Albero. And I think your presentation reiterates again and again that as a medico, we have to keep on learning. And sometimes we unlearn what we have learned previously and learn again. And I understand that though it may seem very complex for new, learners who have gone through this classification, the first time, but definitely what the message is that where the topography of the placenta is it in the upper or lower? Is it anterior or is it lateral or is it posterior? And specifically, that will tell us whether the bladder is resectable or not. If you can resect and pull down the bladder, then that is the case where you can do a conservative surgery. If the bladder cannot go down, then there is no possibility of a conservative surgery. And of course, it's not that easy, which I'm trying to tell, but I think the learners have to go back, read, and come back again and look at the videos again, look at the presentation again, and then they will be able to understand what a surgical classification is and how a topographic classification looks like. Thank you so much, and I think your further videos and lectures is going to tell us more about what is a one-step conservative approach and how you should go about, dissecting from laterally and coming and pushing the bladder down. Thank you so very much.
Thank you, ma'am. Since time is the essence and we are already 27 minutes late, I thank our chairpersons, Professor Bagga, Professor Tayade, and Professor Surekha wholeheartedly. And we move on to the third session. I give the baton to Dr. Indira. Over to you, Indira.
Good evening, everyone.
Indira, you're logged in from two devices, then you have to shut off one.
Or at least mute one.
I hope you're liking it, Dr. Prateek.
Fantastic. Amazing videos, fabulous evidence.
And the best is yet to come.
And all
Oh,
original.
best is yet to come. Yes.
I think this speaks volumes for what ICOG does. We don't recycle old presentations.
Absolutely.
Everything that we speak is new, is original, conveys a clear-cut message, and this can be implemented by ordinary OBGYNs and practice.
Absolutely.
That is the best thing, that you may not do PAS, but you will understand how to resolve complexities of bladder resistance. There's a lot of parallel learning as well.
Indra, unmute yourself. Indra, unmute.
Yeah,
Go
good
ahead.
evening, everyone. It's my proud privilege to be one of the coordinators for the session today. And as in the first two sessions, we've already understood the burden of PAS, the importance of early diagnosis and imaging, and the principles of guideline-based and surgical management by our revered speakers. And with this strong foundation, we now move to our session 3, which will be on strategies and surgeries step by step. I welcome our respected chairpersons for this session, Dr. Jyoti Bindal ma'am and Dr. Savita Singhal ma'am. Nilima, please kindly show the slides. Yes. Dr. Jyoti Bindal ma'am is a distinguished academician and senior obstetrician gynecologist administrator, currently serving as provost and founder vice chancellor of Sri Aurobindo University, Indore. She is the recipient of prestigious FRCOG and several other awards. And we are equally honored to have Dr. Savita Singhal madam. Her slide of the CV, please. She's a senior professor and unit head at PGMS Rohtak, Haryana. She is also president of FOGSI Haryana, president AGOI Haryana, vice president FOGSI Rohtak, convener Haryana OB/GYN Society, and she has more than 36 years of teaching experience and many fellowships and awards to her credit. I welcome you, ma'am. I now request our chairpersons to kindly again invite Dr. Alvaro, who had already given 2 talks, and proceed with the session. Thank you so much.
Dr. Jyoti? Is Dr. Jyoti? I had asked Nilima to help her log in.
I think we can
Savita, go ahead.
proceed.
Savita, go ahead.
Am I audible?
Yes, you are audible. Please go ahead.
So at the outset, I'd like to congratulate and thank Dr. Mitra and Dr. Manju for just taking this concept, Dr. Alvaro and Dr. Palacio, to
at a national level. So I also attended the workshop for this at Gurgaon, thanks to both the teachers. And I think the concept which is being taken now, we'll be discussing this since last 2 hours. We are just listening. What are the changes? Means it is all evidence based, basically. Basically, what I want to say, there are 3 things. Means we have to see what is to be done, and we have to protect the bladder. Means bladder is to be avoided, hemorrhage is to be stopped, and hysterectomy is to be avoided. These are 3 things which are our main aim is there. Now, evidence based, as the Dr. Plasho has done so many of these cadaveric dissections, and then how he found out that what is a blood supply. That is a basic thing to prevent the hemorrhage, to decrease the hemorrhage, I will say. And also time is also one of the important thing which we should take into account, means how much time, because meaning by if we are taking too much of time, it may lead to little more hemorrhage. And then one new concept which today I came to know, that these new vascularization, means every time we're learning new things. So the new vascularized vessels might not be acting to these coagulation. So that is also new. I was not knowing about this, that they may not be responding to this vascularization. And now means this he will be telling about what is very good, beautiful thing about this is the staging, means surgical staging. Is how to stage this placenta, this PAS. That is very, very important, because so many times we're relying on the MRI findings. Ultrasound shows placenta PAS, then we go for the MRI. But in most of the cases, what is my experience? This MRI finding, because we don't know who is reporting this and who is doing this, because they're not at one center. So the reporting is not mustard and not correct. Sometimes we say, one time was like that. If the report was placenta accreta on MRI, I will say it not come out to be MRI. Sometimes it was other way around. Means if it was showing was PAS, it was not the PAS on the OT table. So this is beautiful that how he told about the surgical staging of the PAS. So that on the table itself, because we may not rely on these MRI, how we can decide what is to be done for what thing. So now he will be showing about the one-step cesarean section, we will say. I think it's just somewhat similar to triple P procedure. Dr. Pratik and everybody, there was one triple P procedure we started for Placenta Accreta about 5-6 years and used to say, just remove that chunk of the myometrium along with that. So let's see now how Dr. Alvaro is going to say, means just giving the knowledge about that different types. And what beautiful thing what I learned about this is the subtotal hysterectomy. That is very good concept of subtotal hysterectomy. Means just you are like getting the lower part and leaving whole of
Savita, we
the.
will do that later. Please let the first talk be finished. Huh? Don't mind.
Okay, yeah. I just welcome Dr. Alvaro. I think now he needs no discussion, no introduction. And everybody knows. So he will be just
Thanks,
presenting the
everyone.
one
I
step.
hope you're enjoying this meeting. Let's keep talking about Accreta. And
Welcome,
now
Dr. Alvaro.
some slides about one-step conservative surgery. So how to choose one another surgical technique. The first thing is that under today's knowledge of Placenta Accreta spectrum, we cannot keep saying that hysterectomy is the only option. We have a lot of options. Of course, hysterectomy is the most widely applied technique, but we also have leaving the placenta in situ with a lot of paper from France and different kind of uterine sparing surgery. The most well described are the one with the most evidence is one-step conservative surgery. Each of these techniques has different characteristics, advantage, disadvantage. So there is not something like the ideal treatment for all the patient. Different clinical situation, different setting, different skills of the surgeons will demand different techniques. But we always need to focus on individualization of the treatment, saving resources, offering the better clinical results, and of course, patient expectation, because patient expectation is not just about fertility preservation. A lot of studies like this show that even in high-income countries, patients with not don't looking for more kids, want to keep their uterus, and that is very important in the decision making process. So how to be sure that you will succeed if you try to do a focal resection or not. How to be sure that you are in front of a case like this in the left and not in front of a case like this in the right, in which if you try to do focal resection, you will fail and you will have a heavy bleeding episode. The answer is applying surgical staging and topographic classification, because it's not just about being good surgeon. You also need to improve, include innovation, audit your results, and disseminate your knowledge, and also incorporate knowledge from other colleagues. That is clinical excellence in PAS, is the same as continuous improvement under the best evidence available. So hysterectomy is not the only option. This is the key message for this first part. And if we are working in a reference center for PA, we need to master all the options and offer individualized treatment. How to do it? This is a proposal for a protocol. So applying intraoperative staging, opening, as we said, as we showed before, the surgical staging include the dissection of the bladder, the opening of the parameter, and the visualization of the anterior and lateral wall of the uterus. After doing this, you can apply the topographic classification, choose one of the different categories, and ask yourself these three questions. Are you able to dissect the bladder, yes or not? Have you enough tissue to think on do a focal resection and then reconstruct the remaining uterus, and that is having 2 centimeters below the bulging and having more than half of the uterus circumference with healthy tissue. Fortunately, most of the cases are upper anterior, and you will answer these three questions with a yes, and you can apply focal resection. So you need to ligate the colpouterine pericle. Remember that these pericles are critical in the lower uterine segment blood supply. And after ligating these arteries, you can do focal resection and reconstruction. Please take a look on this video. In this paper, you can scan this QR code. You can access the videos, and don't try and do it yourself. Ask for help or supervision from colleagues around you that already mastered this technique. It is not anymore about research topic. It's not just for super expert surgeons. This is a randomized control trial feasibility study that show that focal resection is as safe as hysterectomy. And when we compare both of the groups, we found that there is no difference in terms of blood loss or surgical time or complication. But when we compare the upper anterior lesion, that is type 1, we found that this lesion in the upper part of the anterior wall will have better result when we apply focal resection. Take a look on this line. Is the length of the surgery is 2 hours for focal resection, 3 hours for hysterectomy. And the frequency of transfusion is twice when you apply hysterectomy. For example, 82% of the patients receive at least 1 unit of red blood cell red blood cells. And in the focal resection group, that percentage is only 46%. So it seems to be safer, better option to do focal resection for patients with lesion in the upper anterior wall of the uterus. And that is not only for places that handled a lot of cases. This is the experience in Switzerland, only 3 to 6 cases per year they are applying, and the same for Poland, the same for Lithuania. So even in hospital with low numbers, the multidisciplinary team that used to take care of this patient can apply these new techniques after some training that can be virtual. So we need to collaborate, really. It's not about being the best surgeon. You need to incorporate techniques from colleagues that have a lot of evidence. But it's not for all the cases, because the cases with the bulging or abnormality below the peritoneal reflection are very complex. Why? Because you will have this very complex anastomotic arterial network with a very narrow space because of the bone pelvis, and with a close proximity with ureters and vascular and nervous structures. So, of course, sometimes you will answer with a no to these three questions, and you will need to apply total hysterectomy and special techniques. For example, ureteral stent if you have a low lateral bulging, or subtotal modified hysterectomy if you have a case with vesicouterine fibrosis. So it's not for all the cases. The one is a conservative surgery. You need to choose properly the candidate for this kind of surgery. How to do it? First step, again, opening the lateral wall of the uterus. The safer way to do it is to opening the anterior sheath of the broad ligament. You can pull the wrong ligament, or you can pull directly the anterior peritoneal sheath, and you open it, and you put your finger inside, moving one finger to the lower part and another to the shoulder of the patient, opening with your finger these spaces and showing and directly evaluating the lateral wall of the uterus to rule out lateral bulging. The same in the opposite side, and then moving from this lateral space to the lower pelvis to evaluate the medial paravesical space, and now to the midpoint to evaluate the retrovesical space. This is the Pelosi maneuver that allowed you to feel if there is some fibrosis or not. Then you pull the bladder with Alice clamp, as you are seeing here, and you individualize one by one the vesicouterine pedicles, ligating it. You can use advanced bipolar energy if you prefer, but simple ligature is enough. And when you dissect all this area and you confirm that you have an upper anterior relation, you can proceed to the delivery of the baby. This is a case after the bladder dissection. Are you seeing the bulging area in the anterior wall? And then we cut 1 centimeter above this bulging area. Of course, we will find placenta there, but we will use ward maneuver. We will avoid to go transplacental. We will detach the upper border of the placenta, putting our hand between the myometrium and the placenta, detaching this area, and doing like a controlled abduction there, just like this, putting our hand in the between of the placenta and the myometrium, then rupturing the amniotic sac and delivering this border of the placenta to catch and deliver the baby. After delivering the baby, we externalize the uterus, and if you have bleeding from the borders, you just put ring clamps in the borders, including the placenta, and you can allow late cord clamping and early bonding if necessary. Then you complete the evaluation. You put the colputerine stitches here in the midpoint and both of the sides, so 3, 6, and 9 o'clock. This is the topography for the colputerine vessels running up from the vagina. And we evaluate if we have more than half of the circumference with healthy tissue, 2 centimeters of healthy tissue below the bulging. And if the answer is yes, you can do a focal resection just like this. After you deliver the baby, the myometrium contracts and you can see clearly the border between the myometrium and the bulging area. Remember, this bulging area is not really a part of the uterus, it's the ceiling of the isthmus cell full of placenta. And now, after putting the 3 stitches on the colputerine pedicles, we perform the focal resection. So we use a cold knife. This is faster and easier. We do a round cutting below the bulging, trying to remove in block the placenta that is still attached to this abnormal area and all the bulging area. That, remember, is the ceiling of the isthmus cell full of placenta. In this case, we are not using a tourniquet, but I really recommend you to apply a tourniquet with a simple sterile glove or a Foley catheter if you prefer, and you will save even more blood, and you will have a very, very calm situation, especially because the first cases are stressful, and your team, your anesthesiologist, will start to worry about any amount of blood that you have in the surgical field. So you remove the placenta just as in a case of placenta previa. And then you will have this big hole that is closed with 3 U-stitches. And then a second layer of unlock continuous absorbable suture. How to train? Simulation is the best option. Telemedicine is also useful. We are doing video call, simple WhatsApp video call, guiding local surgeon that has a lot of experience. They only need some key advices during surgery to succeed during the focal resection. And of course, we can do live training, or you can visit centers like Indonesia, Egypt, or center inside India that already are mastering or applying these techniques. So open to discussion. Thank you so much. And let's stop sharing screen.
Indira, I think back to back, please invite Dr. Jyoti if she is logged in and get the second video to be played.
Indra, are you logged in?
Yes, ma'am. Yes, ma'am.
So, beta, let's get Dr. Jyoti to come in and start the next video.
I think we can start. I think, yeah.
Yeah, otherwise,
we
I
just have
request
15
Dr.
minutes
Jyoti
left.
Bindal ma'am to kindly invite Dr. Albaro for the next video.
Thank you so much, Dr. Albaro. It was wonderful watching this video once again after Indore. And it was as amazing as earlier. And I'm very sorry for all those who could not attend your program earlier physically, but I'm sure there will be a next chance. So once again, can I invite you for your next video, please?
Okay, friends, let's keep talking about Accreta. And this is another surgical technique that we want to discuss with you. This is called modified subtotal hysterectomy. And it is very useful for cases in which you cannot detach the bladder from the placenta, from the uterus. You dissect, you start to do the bladder flap, but you stuck. So first of all, let's talk about the ureteral lesions. So remember, we propose always to try to do the bladder flap, the retrovesical dissection before deliver the baby. And most of the cases, you can do this. You can pull the bladder, you can identify the vesicle uterine pericle, you can ligate it. But some cases is very difficult. For example, in this case, in this patient, we tried to dissect and we found a very fibrotic, dense adhesive area. And for example, in the moment we tear the bladder, can you see the hole in the bladder? Because we were in the wrong plane. So sometimes you start again from behind this area and you found the surgical plane, but that was not the case. We try to do Pelosi, we deliver the baby, we keep trying to do bladder flap, but we don't reach a very good dissection plane. And of course, we perform the hysterectomy, but look how broke was the capsule. And of course, we finish the ultrasound, but look the ureteral catheter. So we have a ureteral damage and a bladder tear. So how to avoid it? Look, this is the ureter. You will see a jet of urine. Can you see it? So it's not about finishing the hysterectomy. It's about decreasing the risk of this kind of complication and decreasing the blood loss amount. Sometimes you finish the surgery and you have this kind of picture. So where is the uterine wall in this case was left attached to the bladder because was dense adhesive and a concrete-like adhesive area. So you have only two options, to tear the bladder or to tear the capsule. So in the topographic classification, when we ask if the bladder can be dissected or no, and if the answer is yes, is no, this is a type 4. Remember, not all the cases are like this. Most of the cases you can dissect it, you can use surgical staging, but some cases the answer is not. That is fortunately less than 10% of the cases, but all the options are bad in this patient. This is a very severe case. Patient can die because of this, and patient can have heavy bleeding. So we will talk today about modified subtotal hysterectomy as an option for this kind of patient. Type 4, lower lower anterior lesion, plus fibrosis, in which you cannot detach the bladder. It's impossible to detach. What is the problem? In this area, you will find this anastomotic circle. It is called cervicotrigonal anastomotic circle, just behind the trigone. So if you can detach it, okay, you can control the pericles, the arterial pericles. But if not, and you tear this, it will be very difficult to stop the bleeding. Why? Because all the different arterial pericles to the bladder, to the vagina, and to the cervicoisthmical area on the uterus are interconnected. And because you will have the ureter here and a very narrow space because of the bone pelvis. So this is a paper from Dr. Palacios evaluating the clinical result of 32 patients with this kind of lesion, comparing with the other kind of accreta, and you will have always worse results. Can you see? 4 hours of surgery versus 1 hour, 1.5 hours, 2.5 liters of blood loss versus 1.5, and a lot of complications. 90% of transfusion, 20% of laparotomy, 4 units of red blood transfusion in this patient. So bad results. And when we compare patient with the same topography, I mean lower anterior, but 90 patients in which you can detach the bladder, this is type 3. So lower anterior, you can detach the bladder, this is called type 3. And lower anterior, but you cannot detach the bladder, this is type 4. So same topography, lower anterior wall of the uterus, close to the cervix, but detaching the bladder or not. Look how different they are. So this is a very well-described phenotype of patient. So 4 hours of surgery, 2.5 liters of blood loss, and a lot of complication. So what option we have for this patient? One is to keep trying to do total hysterectomy, resect one part of the bladder, and remove the uterus with this part of the bladder. This is a bad option, especially if you have a lower lesion, because you can remove the trigone, and that is a disaster. Another option, to put one part of the uterus and leave it attached to the bladder, remove the uterus, and then deal with this wall of the uterus that was over the accreta area and will bleed a lot. So you will need to put a lot of stitches. Look how much stitches there are in this area, because everything will bleed. So both options are bad options, and we will present you a third option that is called modified subtotal hysterectomy. You can go, please, through this paper. This paper is from Dr. Jose Palacios with good drafts and a good video to explain step by step this technique. So this is the case. We already delivered the baby, we sterilize the uterus, we try to dissect the bladder. In this case, we dissect the left side of the pelvis and the right side, but we have this area attached in the middle line. We try, but finally it was not possible. So first step, let's decrease the time to control the bleeding. So before starting the bleeding, let's put a circular suture that will help us to control the border. So when we cut the stump, everything will bleed. So we place the circular suture to control the borders. Look that we already performed lateral cuts from the wrong ligament, uterine ligament, uterine artery. So we complete the hysterectomy regular, I mean as usual, laterally, till we reach this area of fibrosis. Can you see the fibrosis here in this area? So we place this circular suture, 2 circular sutures. The upper circular suture will help to avoid, when we cut the uterus, all the blood from the fundus split on our surgical field, and the lower will help to control the borders bleeding. So now we are ready to cut in the middle, and if we cut the accreta area, everything will bleed. So before cutting this, we apply manual compression of the aorta. So look, this is the same case. Nothing is bleeding because we stop before the bleeding starts. We prepare, we move the guts to the cephalic sector, we palpate we feel the promontorium, then we feel the aortic pulsation, and we put everything in place. You will see how we use this gauze to compress the aorta, and we accommodate the arm of our assistant to compress the aorta. So everything needs to be ready before cutting the stump. Now we will cut the stump, and you will see how nothing will bleed, because the blood flow to the pelvis is close with the manual compression of the aorta. So now we have this stump attached to the bladder and full of placenta. We need to remove the placenta. Sometimes you can pull it, sometimes you need to cut it because it's strongly attached. You need to be careful, because if you cut deeply, you can go into the bladder. So look how general, most of the cases has a posterior wall of the stump that is thick, is it is healthy. I mean, it's not as thin as the anterior wall. And we will use this posterior wall to compress the anterior wall. So now we have this stump. In this moment, after removing the placenta, we close the circular suture to control the borders bleeding. And now this is the most important part, because we have this stump that is closed in the upper part, but is bleeding inside. If we remove the manual aortic compression, everything will bleed. So we use this compressive suture that use stitches entering from behind, from the posterior wall, reaching the anterior wall and closing the stump, using the posterior wall of the stump like a hemostatic patch on the anterior wall of the stump. What is the problem? You can enter the bladder, of course. But if you think in all the other options, you will enter the bladder also. So everything will be under manual compression of the aorta, remember. And we need to close this stump to avoid bleeding from inside to the vagina. So sometimes you need 4 stitches, one in the left, one in the right, in the lower part, another in the right, another in the left, in the upper part. How many stitches will you need? It will depend on the size of the stump. For that reason, you need to dissect as much bladder as you can to lift the smallest stump possible. But never close the abdomen before checking vaginally, because sometimes you can see nothing is bleeding in the abdomen, but the patient is bleeding through the vagina. So before closing the abdomen, ask your colleague that made a vaginal examination and try to put the finger inside the cervix. If the cervix and the lowest and the uterine stump is open, you need to put additional stitches. So never left the operation room before being sure that everything is hemostatic. In this moment, you perform the final evaluation of the hemostasis, and this is the stump from which you remove the accreta, the placenta, and this is the bladder attached to the stump. And performing, when we compare in this series patient treated with modified subtotal hysterectomy versus patient treated with total hysterectomy, look that this patient bleed 2 liters and this patient bleed 3 liters and have less complication, 20% of complication versus 82% of complication. So it's definitely better to perform a modified total hysterectomy than performing a total hysterectomy. Remember, check the video, check the diagrams, and simulate. How to simulate? You can go to this paper. We build this paper instruction that you can yourself, you can with your team build this simulator. We used the simulator at the beginning of this year with Dr. Mitra and Dr. Manju in 4 workshops in India. You can do it yourself. But I mean, we need to remember, of course, we're talking today about one-step conservative surgery, but this is for most of the cases, but always you will find these several cases in which you need to have another alternative, an extra alternative. And modified subtotal hysterectomy is a very good option for this severe case in you cannot dissect the bladder. Intraoperatively, identification is this patient, you try to dissect the bladder from the ultrasound evaluation is quite difficult yet. But even if you're the best, this kind of patient, please, if you found this kind of patient, please stop, think, organize your team, plan, apply manual compression of the aorta, and think in this technique. Thank you so much. I hope we have time for questions. Thank you.
Yes.
I sincerely thank Dr. Albaro. It was so wonderful to attend your workshop at Kolkata and attended all these simulation stations. So today also we have witnessed extremely great videos again. And thank you so
Can
much.
we have Dr. Albaro spotlighted? Dr. Albaro
I invite
spotlighted?
Dr. Albaro, sir, please to give some comments and closing remarks.
And also we have to invite Dr. Sheila for
After that, Dr. Sheila Mane ma'am to give the closing remarks and wrap up the session for today.
Do we have Dr. Albaro? Mitra,
Yes,
logged
ma'am.
in?
I saw he is there on the panel.
Dr. Albaro, please, if you
I
can
think
open your video.
if Nilima can
Otherwise-
spotlight Dr. Albaro and Dr. Sheila at the same time, that'll be good.
That would be excellent. Yeah. Or maybe he's driving or something, Mitra. It is
Yeah, he was
possible.
going to.
He's there. I'm here. I'm here, but I don't want to spend too much
Yes,
time.
yes,
in the
welcome.
No. I was here all the meeting, and thank you so much to give me 4 talks. And it's great always talk with you all. No, I think everything is safe, and you are doing big things. You are changing in your country your protocol, just as we do here in Colombia. And as we talked in previous meeting, all these concepts can be applied daily for complex dissection. It's not only for PAS, because bladder first is the same for the histens, for fibers in the lower uterine segment, or even for placing a compression suture. So thank you so much for inviting me and for keep disseminating this concept. Thank you so much.
Thank you, Dr. Albaro, for taking the pains to record, re-record, and re-record, and being there for us. We really appreciate your love to teach.
And overall, I think it's an amazing insight for everybody who was there. I don't think any of our new joinees have ever seen this kind of work and totally new concepts in PAS. And kudos to Dr. Mitra Saxena and Dr. Manju Puri for bringing this to everybody's doorstep. Thank you for having me here. Thank you so much, Mitra.
Thank you.
Imagine, Manju, one of my patients delivered. I'm sitting right in front of labor room. I didn't hear.
Chalo, we can have Dr. Sheila. Let's have Dr. Sheila, because we would want everyone to know about the PAS registry, you know? Yeah. Oh, this new baby's come. Oh, okay.
I had some problem. I think I'm again joining from my system. But meanwhile,
we can see you and we can hear you, Doctor.
Yeah. I have logged in from my phone, but I'm waiting to log in from my system so that I have some slides which I would like to project. And I think, yeah.
So all in all, I think it was a very interesting session, and I'm sure people must have got a lot of new ideas and new introduction to new concepts which are coming up.
Can I ask the backend team that I would like to share? If backend team can help me to share?
Yes, ma'am. Madam, if you want me to share the 3 slides, I can do that.
Yeah, please. Yeah.
I'll share. I shall share these 3 slides and then you can...
Yeah, sorry. Thank you.
One second. One second. Oh, 1 second.
I think
actually how to go to my...
I think there is so much of material. I think as both of you have,
Shreya, can you tell me how to go to my desktop? 5 minutes. I want to go to my desktop, Dr. Sheila.
So can backend team help me? Then I can just share.
मैम
Can you
आप
give me the
Zoom
share
मीटिंग पहले
option?
यस मैम शेयर पे क्लिक कीजिए मैम.
Can you give me the share option?
यस यस मैम यू आर co-host मैम.
No, but I'm not getting that share option.
मैं
Meanwhile,
इसको
whatever
बंद
you-
करती हूँ. मैं मेरा हटा दो.
नहीं मैम अभी स्क्रीन पे कुछ नहीं है. शेयर पे
You are
क्लिक
co-host, you can share, ma'am. For
And
those
all
of
the
you who have
delegates
internet
to
issues,
note that after a week, this whole presentation will be available on ICOG website. So all the videos, everything, whatever is there today, it's a recorded program and it will be available. Okay. Is it possible, Mitra? What is happening?
Yeah, I will.
So, dear friends, we are starting this PAS registry. Just a few, nitty-gritties we have to solve with the IT people, and then it will be, we will float it. And I'm just trying to see that how I can reach to everybody so that we will be able to collect more data. And Dr. Albrado, I think we were again, I think today you have sensitized us that how large is your work and how much of data you have. And we are just starting now. So
Dr.
I
Sheila,
think,
you can start reading
yeah,
from
yeah.
here.
So I think Dr. Mitra, oh, again the slide is gone.
1 second, 1 second. Again, some problem has happened.
So this concept, I think I looked at your slides that how much of data is collected. And I hope that after listening to your talk, I think Dr. Manju, we have to just see whether we have to add something to this, according to the data, the way they have collected. So we will have a relook once again in 3-4 days and then see to it that it becomes more effective. So that was
Dr. Sheila, you can
very
see it
useful.
now.
Yeah. So now all of you have learned by this time now the aims of this masterclass. That is, we have to create past champions because we know that we don't want to lose mothers and even to have a morbidity with massive blood transfusions. So one has to be past conscious, past competent, and documented. So the documentation will play a very big role, and all of you learned from the Albrado and so many other studies. Okay, next slide, please. So there are 3 pillars now. When we say conscious, it is the mindset shift. So for every patient with previous LSCS, we'll have to rule out PAS actively. We have to scan with suspicion, placenta overscar, lacunae, loss of clear zone, bridging vessels, and document. So the PAS risk assessed and entered in every NC card. Then PAS competent, that is skill set shift. For every diagnosed suspected PAS, you will understand and rationalize which pedicle to tackle to arrest hemorrhage, bladder dissection and delivery of the baby, perform surgical staging to assess the operability based on the topography and choosing the safest option, proceed with full preparedness, that is OT huddle, blood preparation for vascular control, plan A, plan B with competent team. And documentation, data set shift for every past surgery performed, send HPE always, extirpated uterine wall plus placenta or hysterectomy specimen. Establish final diagnosis, clinical suspicion, and pathological finding and confirmations, and contribute to registry. Your case becomes a part of Indian data. And I think those who have attended today have understood now. But I think we will have to make maybe a small PPT, Dr. Manju, which we share with people, those who are going to, as far as possible, if we are able to talk to them about topography and the staging and the vascularity will be very, very useful. So thank you all for joining today.
I also want to add one small thing, Dr. Mane,
Yes.
is that Dr. Albero has started a multi-centric study. And if
Yes.
anybody is interested, the documents will come, the exact protocol, the ethical committee clearance, everything is there. I am happy to share that with anybody who's interested in starting the study at their centers. I have the full details.
I think those who are having many cases, okay, like Dr. Manju, we can just think about it, and then through ICOG also, or anybody I think can join. I think that was a very good information.
Yeah, so when they share in case they want to be a part of that multicentric study, they should share data with us also, so that we
Yeah.
can compile the Indian data also simultaneously, right?
Yeah.
So it could be shared with them, shared here.
Yes.
So that is how it should be.
Yeah.
Right.
As we are repeatedly telling, recording will be available on the website within a week. Okay. So then again, I take this opportunity to invite all of you to Bangalore for ICOG National Conference. Nilima, can I have those slides? Okay. And please utilize it. Again, we will have this workshop. So those who have not attended today's masterclass, we will have this workshop in Bangalore conference. So, and everything is available now on ICOG website. We have shared the website for the conference also. So please log in, register early, and be there in Bangalore. Thank you. Pratik, yeah, over to you.
So thank you very much to all our respected faculty, the coordinators, the conveners, all the eminent faculty and our international faculty who gave time for this excellent masterclass. As I'm so fond of saying, ICOG stands for Excellence in OBGYN Teaching. And today's masterclass was truly an echo of everything that ICOG has set out to achieve since 1984. Thank you very much, all of the respected faculty who gave time from their busy schedule and shared their knowledge with us. We had 450 plus attendees at one point in time during this wonderful masterclass. For those of you who might have missed certain sections owing to internet issues, or you missed some of the slides, the recordings will be available on the website. As Dr. Sheila Maniman said, we are launching this PAS registry. I strongly recommend all of you who are in teaching, who are in medical colleges, and who have cases to contribute to the registry so that common OBGYNs who don't normally understand and come across these cases, that once in a lifetime when they do come across these cases, they should be empowered and equipped to deal with PAS, and that will ultimately end up saving somebody's life. So please join this mission, contribute to it,
Yeah.
and the more the merrier. Thank you very much.
Log on to ICOG website after we create a user ID and all the details. And again, we will try to reach out to everybody as far as possible, most of the institutes, those who are doing the surgeries. And I thank Dr. Mitra for recording, pre-recorded and properly played. You know, she has devoted so much of time for this on her own. She has done this, all the recordings. Thank you, Mitra. And thank you, Dr. Manju Puri, for bringing this to India.
I think Mitra and Manju can be Lakshmikant Pyarelal, Shankar Jaikishan, Manju Mitra, something like that.
Thank you, Dr. Sheila and Dr. Pratik, for the opportunity.
Yeah,
And so we
definitely.
thoroughly enjoyed conducting this.
And I just would like to put one little sentence, Dr. Sheila. Now that you have apprised everybody about the PAS registry, Manju, I think once we get data from the PAS registry, then we should formulate the guidelines. We should not be in a hurry to copy guidelines of this one and that one.
No, we'll
build our own data and then, Hannah.
The
Thank you,
process
Dr.
can be
Sheila.
started and that can be incorporated.
Yeah.
Thank you.
Okay. Bye-bye.
Thank you, everyone.
Delegates.
Goodbye. God bless. Thank you, everyone.
And thank you, ICOG team, to be there with us. Thank
Bye-bye.
you,
Have a
Dr.
nice day. Bye-bye.
Always.
Thank you, Albano.
Thank you,
Thank you,
Alvaro. I
Alvaro.
think,
Thank you, Alvaro.
Nice to see you again.
Thank you.
Bye-bye.
And welcome
I
in
think
advance. for
your
India.
presentations have made people to change their ideas. I think all doubts were also cleared, and excellent videos. And I think it will definitely help people to change their management, conservative, as well as you showed that subtotal hysterectomy, and then bladder dissection and ligation, everything awesome.
I hope so. Thank you so much. Very nice joining me. Bye-bye.
Bye.
Bye-bye.